The mission of the Marfan Foundation is to save and improve lives while creating communities for all individuals with genetic, aortic, and vascular conditions, including Marfan, Loeys-Dietz, and vascular Ehlers-Danlos syndromes. These conditions affect people worldwide, and it's our goal to support them, their families, and the medical professionals who care for them.
As we've come to better understand the science behind these conditions, we've expanded the foundation to include these 4 divisions.
Since we have had the backing of the Marfan Foundation, things have just so rapidly gotten so much easier and better for parents and families.
If you have a collection of doctors that are working on your issue at the same time, you get a much more complete answer, and that's what the foundation brings to that.
Partnerships are absolutely the key to victory, and that's why we're grateful to have the GenTAC Alliance as part of the Marfan Foundation.
It's really led to fantastic international collaboration in the research realm, in the patients, families, and clinicians area, in clinical research, in database growing, in finance and business aspects to help support this.
The research that the Marfan Foundation has supported for many years has led to a better understanding of genetic, aortic, and vascular conditions. It's also improved the lives around the world for those who are affected.
When I was born, the average life expectancy for someone with a genetic aortic condition was 30 to 40 years. Now with medical intervention, people have normal lifespans.
It's amazing how much the education has proliferated to other professions within the medical community, not just primary care physicians, not just emergency physicians. That push, that drive to educate all these medical professionals has had tremendous results.
The information that is provided by the Marfan Foundation on its social media and on its website is backed by the medical professionals that are experts in vascular Ehlers-Danlos syndrome, and it's the most trusted source for information in the United States.
We have an amazing help and resource center for affected people and their families. It's usually the point of entry for somebody that has been diagnosed with one of these conditions, and it's the beginning of their journey.
It has been so helpful because the questions I didn't know I had, they answered. I put in a call to the nurses line, and then it just relieves me and gives me, peace of mind. I'm very thankful that it's there.
The biggest thing that I think people learn when they come to conference is if you have a question, someone's probably most likely experienced something similar, and it gives you a peace of mind to know that you can reach out and ask those questions.
The most amazing part is the medical assessment area, where I was able to meet renowned specialists in different fields, and also I met Marfan community.
Camp is the place where my heart really resides because camp is a really great, safe place, and you can feel comfortable while also learning that independence in a place that doesn't make you feel different for what you can't do, but celebrates you for what you can.
The Marfan Foundation has allowed us to connect with people that's just like you, just like so many other people with this condition. So without the Marfan Foundation, a lot of connections would have not happened.
The foundation is recognized throughout the nonprofit industry for its commitment to accountability and transparency. We are diligent in how we use our resources, and I'm proud to say the foundation has received the highest ratings on Charity Navigator and GuideStar.
Historically, the foundation has supported international research in genetic, aortic, and vascular conditions. As we expand our mission, we're now looking to provide additional patient support and awareness in locations outside the United States. For example, our website is now available in more than a dozen languages, as well as a number of our other research materials.
I know that there's other people with Marfan in Costa Rica, but I've never been able to connect with them. Once you connect with that foundation, you're never gonna be alone again.
So I think the value of having all of the aortic conditions together in one community, it's more of feeling like you're at home.
I've made some of my closest friends through the foundation. It was definitely helpful to just see that I'm not alone.
I've gotten to not just live longer, but actually the level of my care is vastly better.
I'm living successfully with Loeys-Dietz rather than living in fear of Loeys-Dietz.
The future for individuals and families with genetic aortic conditions has never been brighter.
Good morning, everyone. I think it'll take a few minutes for the coffees to kick in. My name is Ibrahim Sultan, one of the heart surgeons at UPMC. On behalf of Dr. Singh and Dr. Hoskapal, Marfan Foundation, thank you so much for spending your Saturday morning with us. Really, you know, as physicians and surgeons and doctors, we do several of these symposia that are targeted towards doctors who refer you to us or who call us about your conditions. But, you know, this is really the most special in our minds and hearts, you know, no pun intended, which is this is focused towards the audience that we want to communicate with, we want to get to meet and spend some time with. So again, thank you so much for taking time away from your family, and some of you are here with your families, which is wonderful. The goal here, again, is to get together a network of patients and families and support folks, of folks living with conditions of aortopathy, typically. So Marfan's, VEDS, Loeys-Dietz, and other familial aortopathies. Now, what we'll try to do during this morning is really go through some of the talks that may be focused on conditions and associated conditions that you or one of your loved ones may be living with. They're meant to be relatively short, 8 minutes, so very easily digestible. We'll have a Q&A session. Dr. Singh, Dr. Hoskapal, and myself will try to moderate and engage as much as possible. No such thing as a bad or silly question. Feel free to ask. That's what we're here for. Once the boring part is done this afternoon, we'll all go to a social event, which I don't remember the details, but Angie will tell us all about that shortly. So again, once again, thank you so much for coming. I will ask Helene, who is the Chief Community Development and Philanthropic Officer, I want to say, of the Marfan Foundation. I should know her. I should know this by now. But she'll speak to you a little bit about what she has done for thousands and thousands of patients and what the Marfan Foundation has done for everyone. So thank you and welcome, Helene.
Can you guys see me? You always need a step stool here. So I'm Helene Baruch from the Marfan Foundation, and I am so honored to be here. And I really want to thank Ibs, Angie, Krista, Arvin, Derek, and all the docs over there for helping us make this happen for the first time. I'm going to actually stand on my tippy toes. You know, we do about 4 symposiums a year, and we haven't been to Pittsburgh. It's our first time. I think what is exciting me about being here is obviously hearing the wonderful presentations, but it's you guys, the families. We have every condition in this room represented, Loeys-Dietz, VEDS, and Marfan, and I know there's some families that just met others for the first time, and that's really what it's about. So I hope you get the opportunity to meet others while you're here. The foundation is in California next week. We'll be in Austin, Texas. We'll be in Boston doing these symposiums, but like I mentioned, first time in Pittsburgh. The foundation's been around for about 42 years. You know, we started really as a research arm. We've funded now over $20 million plus in research since we were founded. Some people might have even gotten our research grants who are here, I don't know. It's also, right now, it's up online, so please look for those who are interested in funding. We also brought in 2 new divisions. We brought in the Loeys-Dietz Syndrome Foundation. We are honored to have one of the steering committee members here. I don't know where Julie is, great. Please, anybody here with Loeys-Dietz, please go over and talk to Julie. She's amazing, and her family. The VEDS movement, we brought the VEDS movement in to really focus on that particular community. I'm thrilled that we have some families here from that community meeting for the first time. And then the Marfan Foundation. We'll be hiring a director for that division as well next year. So thrilled to have some new people here and faces. Quickly about some of our programs you saw, I cannot tell you we have so many amazing resources and programs. Please go to our website, marfan.org. It will take you to also the Lois Dietz site, the VEDS Movement site, a lot of great resources. We have support groups, for newly diagnosed, for kids, for teens. So please go on. We do a lot of stuff for that. We have a camp. I think for those of you that have kids or want to be a counselor, we do a camp in July. It's in Atlanta, Georgia, July 20th this year. It's 6 nights. We'll be doing one in Southern California too. We're just getting the dates, but it's just kids, no parents. And we go and the kids have the time of their life. It is everything from horseback riding to archery to pottery to, we do color war. It's a lot of fun. They like to beat us up a little bit, but it's a lot of fun. So for those that have kids or are really interested in wanting to be a counselor, we love docs to be there too, and nurses. So please come find me. We were doing a virtual conference this year. We will not be doing an in-person conference because we're going to be doing an international conference this year in Oslo and up in Norway. So our virtual conference is July 20th, 21st, and 22nd. We usually get anywhere between 2,000 and 3,000 people during our virtual conferences, and they're global. So put that on your calendar. I'm also thrilled that we'll be back in Pittsburgh on May 18th, where again we'll be with UPMC to do our first Walk for Victory. And please, all of you come out. It's a wonderful afternoon. It's just really, we call it a walk. It is a fundraiser, but it's really for everybody to get together, hang out, meet, and have a really good time. If you have any questions, I'm going to be hanging out in the back. I'll be here all day. I will be bowling. I'm not very good, but I will be hanging out with you guys. And again, thank you, and I look forward to kind of hanging out with each of you individually. Thanks for being here.
Thanks, Elaine, and thanks everyone for coming. I'm Arvind. I'm one of the cardiologists who, with a special interest in taking care of aortic patients. It gives me great honor to kick off this session and this meetings by introducing my a good friend and colleague, Dr. Rachel Torak. She's assistant professor of pediatrics, and she's also the director of the pediatric aortopathy program. And she'll be starting off with the first talk. Thank you, Rachel.
Thank you, Arvind. Good morning. I'd like to thank the organizers for the opportunity to speak today. I'm thrilled to be here and really excited to talk to you today. We'll be going through the diagnosis of connective tissue disease. So in 8 minutes, we're gonna blast through the diagnosis of Marfan syndrome, Lois Dietz, and vascular Ehlers-Danlos syndrome. So first, we'll start off with Marfan syndrome. So it's, the incidence is about 1 in 5,000 patients. Marfan syndrome affects 3 main systems of the body: the musculoskeletal system, the eyes, and the cardiovascular system. With aortic dilation, or the aorta getting potentially too big too fast, could lead to a tear in the aorta, and that's one of the major concerns that we look out for these patients. What's one of the screening tools that we use to look for features of Marfan syndrome patients? We use the systemic score that was based off the Ghent criteria from 2010. And this is just looking for features that may be common in the typical population, but if you add these features together in the same individual, then it may raise concern for Marfan syndrome for that patient. And so in clinic, we're often pulling out some party tricks and families play along, where we look and see, does the patient have particularly long thumbs or fingers where they could do the thumb or wrist sign? If both of those are positive, that's 3 points in our systemic score. That's out of 20. If just one of those is positive, then that's 1 point. We look at the breastbone. If it bows out, that's 2 points. If the breastbone goes in, that's just 1. We look at ankles. If this is an example of the hindfoot deformity, where the ankle, sometimes parents are like, I think it almost looks like my child's walking on their ankles. That may be hindfoot deformity, and we have to distinguish that from just flat feet, which is super common. And then less rare things that can lead to 2 points on the systemic score: deeply set hip bones or protrusio acetabuli. That's a radiographic finding. History of a hole in the lung or spontaneous pneumothorax. The hole just happened for no reason. And then dilation of the sac around the spinal cord, or dural ectasia. That would be 2 points in the score as well. Things that look for 1 point, I get out my long measuring tape and measure arms and legs and compare the ratios to the patient's height. If both of those are abnormal, then that's 1 point. If the patient's rather nearsighted, worse than -3 diopters, that's a point as well. We look at facial features. Marfan syndrome patients are often long and lean. Their faces are often long and lean. And we also look at kind of how their eyes are shaped and put together. I look for evidence of the mitral valve bowing backwards, both on exam and by ultrasound. Some patients aren't able to extend their elbow all the way. There may be stretch marks that can't be explained by pregnancy or changes in weight. And then there may be significant scoliosis. All of those would be 1 point. And so my learners know that I hop up and down in clinics saying that a positive systemic score, which is 7 or greater out of 20, is concerning for possible Marfan syndrome, but does not equal Marfan syndrome. I need to know more. And so what am I looking for? I need to know what the echo looks like. Is the aorta dilated? Is there mitral valve prolapse? What's the genetic testing results? Have we looked and found of FBN1 gene mutation that goes along with Marfan syndrome? What's the eye exam look like? Is there a lens that's displaced in the eye? And really importantly, what's the family history? Is there a known family history of Marfan syndrome? And so to make the diagnosis of Marfan syndrome, we first figure, is there a family history or not? And so without family histories of Marfan syndrome, then we look, if you have a positive systemic score and a dilated aorta, that does equal the diagnosis. Other ways to the diagnosis without family history are a dilated aorta and ectopia lentis, or the lens of the eye being displaced. A dilated aorta and the FBN1 gene mutation that goes along with Marfan syndrome, or the ectopia lentis and the gene mutation. Those are all pathways. With the confirmed family history of Marfan syndrome, if you have a systemic score, that equals the diagnosis. If there's a dilated aorta, or if the lens is moved, those are all ways to make the diagnosis of Marfan syndrome. Sometimes it's not clear, so we can live in shades of gray, especially in a young patient. I'm a pediatric cardiologist, so I may see patients early on, and they just may not have developed these features yet. And so for patients who don't have a clear diagnosis, I obtain an echocardiogram. If the echo looks okay with no dilated aorta, then I bring them back. So every 2 years or so, I'll look head to toe, repeat the echo, and look for any features that have developed. I follow borderline patients to the late teens, early adulthood. And then I'm also, at the same time, when I'm evaluating for Marfan syndrome, I'm thinking of other connective tissue diseases that may have overlap with Marfan syndrome. And one of the things that definitely comes to mind is Loeys-Dietz syndrome, where those two can have features that are similar, but they're certainly different diseases. The 4 main characteristics that are identified in Loeys-Dietz syndrome are aneurysms. So usually it's of the aorta that can get too big too fast, but it's also not just the aorta. And so it can be arteries from the head all the way down to the pelvis that can dilate. The vessels may be twisty or tortuous, which is shown here. Their eyes may be widely spaced, showing this beautiful baby here. And then things that my pediatric patients love to show off is their uvula can look pretty cool. And so their uvula may be split like a fishtail or be a little bit wider. And so those are features that I'm looking for, in addition to a lot of things head to toe, not just those 4 features, but other things that we're looking for in our extensive physical exam. Family history is huge. And so I think it's a common pathway of diagnosis is that there may be an event in an adult, and that an aortic event where there was genetic testing that's done. And if we are able to identify a gene that goes along with the types of Loeys-Dietz syndrome that we know, there's 5 types that have been identified to date, that can be huge for this family, because then we can look in first-degree relatives and really help this family and really diagnose patients in the family tree, get them plugged into the care that they need early on. And so I think family history and genetic testing are huge in this family of diseases. That also is the case in vascular Ehlers-Danlos, so family history is huge. Sometimes there's an event that leads to the diagnosis in the adult, but that allows the family to undergo the testing that they need. Genetic testing in vascular EDS is extremely sensitive, looking for the COL3A1 gene mutation. And so knowing your family history is so important here. Other features that go along, the major features of vascular Ehlers-Danlos are arterial rupture or dissection in a young person, a hole in the intestine, a hole in the uterus without a previous C-section, or an abnormal blood vessel connection in the eye called an arterial venous carotid cavernous sinus fistula. Say that 5 times fast. Other features that we're looking for, this beautiful child here has some of the features we can look for. The nose may be narrow, there may be thinner lips, so smaller chin and smaller ears. The hands may look older than the actual patient's age. The skin may be a little bit thinner and you could see the veins. There may be a club foot. Other things that just kind of raise the suspicion of possible vascular EDS if I don't have a family history and genetic testing to go off of. These are pictures of patients who had vascular EDS and had events, and I think this actually just shows the diversity of these patients too. Looking at these patients, I can maybe see some features of a thin nose or thin lips, smaller ears, but I also see a lot of diversity, and I think it's a tough thing to look at someone and make a diagnosis, and I think family history and genetic testing are really huge tools that really aid in this diagnosis. So in summary, family history is hugely important. Talking about the diseases, knowing your family history, making sure that your family members are getting the screening they need is so important, and a lot of why we're here today. Physical features can help. Imaging and genetic testing, also important tools in diagnosing the connective tissue diseases. And there's a lot of overlap. So I think following patients who don't quite fit the picture over time is important. With that, I'll wrap up. Thank you so much.
Thanks, Rachel. And next, I would like to introduce Dr. Anita Saraf. She's Assistant Professor of Pediatric and Internal Medicine. She's also the Director of the Adult Congenital Heart Disease Research Program at UPMC, and she'll be giving the next talk.
Thank you, Dr. Hoskapel. So thank you for giving me the opportunity to speak. I'm an adult cardiologist, so by the time I see my patients, most of them have already been diagnosed either through a genetic test or because they've already seen Dr. Torak. And I am generally taking care of these patients after diagnosis, or I am taking care of patients who are related to this primary patient, and I'm trying to figure out how to best risk stratify them. And I'm going to give you a little bit of an overview of what we think about when we see these patients when they enter into adulthood. So we see a lot of patients who have aneurysms or thoracic aneurysms, and surprisingly, some of these diseases are not the primary cause why these patients have these aneurysms. In patients who are much older, 60 or 65 and above, atherosclerotic plaque and inflammation are the primary reasons why patients develop aneurysms. And so in genetically mediated diseases, the incidence of thoracic aneurysms is actually pretty low at only 5%. And only 20% of patients with thoracic aneurysms have a family history of thoracic aneurysms in general. So when I think about thoracic aneurysms from a genetic perspective, I actually look at the much broader picture of this whole disease etiology. So about 20% of these patients with thoracic aneurysms are syndromic, and that's where most of the patients with Marfan's, Lloyd-Steed's, and Ehlers-Danlos will fall. And then there are non-syndromic TATs, which are generally 80% of the population, of which only 20% are familial, and 80% are non-familial. So most of these aortopathies, the genes that drive these diseases are autosomal dominant in inheritance. They can be affected with non-cardiovascular structures, such as, Dr. Torak described, but some of these findings can be also in isolation. So there's this disease called isolated ectopiolentis, where the same mutation in the fibrillin gene is implicated in these diseases, but they don't have any of the cardiovascular findings in our patients. And based on the genetic mutations that drive this disease etiology, there can be some aortopathies or vascular diseases that are more or less aggressive. In some of our patients who have these genetically driven diseases, aneurysms start at a younger age. And what I mean by an aneurysm is not just a mild dilation of the aorta, but an increase by at least 50% of the diameter of the aorta in these patients who have these syndromic diseases. In addition, you also get aneurysms in other structures, such as the brain or the renal artery, and also the presence of vessel tortuosity. So there's a lot of genetic as well as clinical evaluation that we do in deciding which of our patients are most at risk. So what really is the role of genetic testing? Genetic testing in our patients is most beneficial when we think that it will change medical management or the frequency at which we follow up these patients. Genetic etiology is generally associated with faster aortic dilation than patients who don't have genetically driven diseases. For example, some of these diseases have a growth rate of about 0.22 centimeters per year, which is not quite the criteria that we would use to surgically intervene on these patients, but is an indication that there might be a genetic factor that is driving this disease. It will also help us identify potentially other family members who are also affected and facilitate a conversation about prenatal diagnostic testing and deciding on pregnancy choices. And it also helps us figure out which of these aortopathies are more aggressive versus not, and which patients need to be followed up earlier, like I said before. So right now there are two main commercial gene panels that we use at UPMC to look for aortopathies. One is the InVitae gene panel, which has about 29 genes, and the other one is the GeneDx panel that has about 26 genes. I did look at these closely, and there are 3 genes that are tested for in the InVitae gene panel, which are not in the GeneDx panel, and I have them circled here. But really what this comes down to is understanding which genes and which mutations actually drive these aortopathies over the others. So here is sort of a pyramid chart of the different genes that can be associated with the risk of having aortopathies. At the topmost section, you have the ones that are most strongly or definitively linked to aortopathies, and you can see some genes here with, associated with diseases that we are talking about today, including Marfan syndrome and Lloyd-Steeds. In the middle, we have genes that are linked to aortopathies, but really not in isolation by itself. It depends on how these mutations present. Are they autosomal dominant? Do they interact with other genes? Are there mutations in other genes that are also associated with formation of the aortic structures? And then there are obviously other genes, which are found to have mutations that are not directly associated with aortopathies. So all of these different genes, we are understanding and learning about them more and more over time to further risk stratify mutations and their association with aortopathies overall. Where these genes play a role on the cellular level, and I promise this is the only cellular slide that I will be showing here, is really how they interact with other cells in the extracellular matrix of the vessel itself. So most of these diseases are associated with this one molecule called TGF-beta, and how it interacts both with the receptor as well as the other signaling pathways that then cause the extracellular matrix or the structure around the cell to form itself. What you see here is that when you have these mutations, the beautiful architecture of elastin and collagen, which are the support molecules around the cell, get disrupted because some of the proteins and the proteinases that dissolve these extracellular molecules get upregulated as a result of these mutations. So these mutations, what they really do is disrupt the integrity of the cell and the tissue architecture itself. And where these mutations are located is an important factor in deciding how they will actually affect the structure of the vessel itself. So while we are very used to thinking about these diseases as, this is LDS or this is Marfan's, and this is where you have to intervene to prevent dissection or prophylactic surgery is warranted, what we really need to think about is these genes that drive these mutations or drive this pathology itself. So here you see with patients who have Lloyd-Steeds, there are 3 different mutations that are associated. We would generally recommend prophylactic surgery around 4 to 4.5 centimeters, but there are also some of these genes that are present with LDS4, and there the criteria for doing surgery is a little bit different than you would for somebody who has more aggressive Lloyd-Steeds. So understanding these mutations and the role they play in driving pathology is just as important as knowing the diagnosis, and that's where I think the next step in understanding genetic mutations will take us. So when you do these genetic tests, you generally get a certain set of results. So positive a result suggests that you have a pathogenic mutation that's driving the disease. A negative mutation or a negative result shows that there isn't a pathogenic genetic mutation. But then the one that causes most confusion and stress probably is the one that is called the uncertain one, where there just isn't enough information, either because we don't know about that gene or we don't know how that gene interacts with the cells or with the structure as a whole to know what it will do down the line. To these patients. Are they at risk of dissection? Are they people that we need to follow closely? And that's something that we are continuing to figure out. And there is a lot of clinical mystery around that we are trying to explore further. And we obviously don't do that in isolation. This is one of our genetic counselors, Vicki Bacon. There's an extensive network of genetic counselors here at UPMC that we work with closely to find answers to these patients and help them provide the counseling that they need to make the next choices in their life. So I wanted to sort of conclude by talking about the eligibility criteria for genetic testing. Not everybody who we see gets a genetic test for obvious reasons. A lot of people have mutations that are not clinically relevant. And then the stress that is and burden that is associated with understanding what that really means falls not only on the patient, but also on us, the providers who give them the news that there's a mutation that we don't really know what to do. So the patients that get tested include those that have a thoracic aneurysm or dissection before the age of 50, or who have a dissection before the age of 60 or have an aneurysm before the age of 60 and have a first-degree relative who also has an aneurysm or a dissection. Younger patients less than 60 who have the absence of any cardiovascular risk factors, or patients who have features of aortopathy. And of course, patients who have Lloyd-Dietz and Marfan's, as I mentioned before, they have a variety of different genetic mutations that can be implicated in their disease, and we need to understand them more to further risk stratify them. And of course, our clinical suspicion supersedes all of these different factors, because really as clinicians, what we do is look at our patients, look at their family history, look at their various features, and decide whether we are concerned at all about following them more closely or risk stratifying them differently. So this is one of the flow diagrams that sort of simplifies this entire process that was recently published, also as part of the guidelines. And here, patients who get genetic testing are those who have Marfan's or Lloyd-Dietz, have unexplained dissections or unexplained sudden deaths, or who have an aneurysm and are less than 60 years of age. Patients who are over 60 and are sporadically found to have an aneurysm, we don't necessarily test them for genetic mutations. We do screen their family members, and if these younger family members do end up having a positive genetic test or have an aneurysm, we do test them for genetics. And in that case, if the genetic test is positive, then we risk stratify the rest of the family members. In case of a negative or an uncertain result, what we do is we do image all of the first-degree relatives and put our results in the context of what we see within the family in terms of deciding whether additional members will need genetic testing as well. So in conclusion, my goal here was not to confuse you more, but to make you appreciate that genetic testing is still evolving, and we are understanding more about how these genetic mutations drive our decisions to manage our patients. This is a very complex discussion that involves a whole bunch of different people, a whole bunch of clinicians and genetic counselors, and it cannot be done in the presence of just one factor alone or one clinical suspicion alone. And I think we are continuing to do ongoing research to help us get better answers and better algorithms so that it can help all of us take care of our patients in a more effective way. So with that, I'd take any questions, and thank you for your time.
Thanks, Dr. Saraf. We'll hold off for questions till the end of this session. That was a great talk, and if you're a little bit confused, don't feel left out. I get confused with this genetic testing stuff all the time, and that's why we have a team over here. Anyway, let me introduce the next speaker, which is Dr. Natasha Wolf. She's the assistant professor of internal medicine, and she's an adult congenital heart disease specialist, and she'll be talking to us about guidelines. Thank you.
Hi, everybody. Thank you so much for coming today. This is really special to be talking to patients and educating everybody about all of these different inherited aortopathies. So my topic today is guidelines and management and what's new. So just natural history of inherited aortic disease, life expectancy has increased significantly since the 1970s, largely due to advances in diagnosis, imaging, and medical and surgical treatment. And in 1972, the life expectancy for a Marfan syndrome patient was around 30 to 40. It's now up to 70, and so it's basically normalized with the rest of the population. As doctors, we worry most about what drives mortality, and so that is the aortic and vascular complications that can occur with these inherited aortopathies. So I'd say the biggest update in this field is the newly diagnosed published guidelines in 2022 that were put out by the American College of Cardiology and the American Heart Association. This is just the screenshot of the title. You can find this, it's free and available online. It's 150 pages long. It covers a lot of stuff, but they do nicely divide it into sections, focusing on genetic causes, surgical planning, things like that. And so we're gonna kind of review, kind of broad strokes, the main findings in this guideline, and what we as your doctors and surgeons are reading to guide how often we're seeing you, how often we're imaging you, when we recommend surgery, and things like that. So kind of overall for everybody, the guidelines, this was an update from 2010, so it took 12 years for new guidelines to come out. And they finally kind of really strongly recommended genetic testing, as Anita just went over. But we consider this a lot in people who have features on exam consistent with inherited aortopathies, a family history of disease, or early onset of the disease. And so those are often reasons we get patients referred to us for evaluation and for consideration of genetic testing. The guidelines do also recommend overall that surgical treatment be done at high volume centers with experienced surgeons, because that has been shown to improve outcomes. And a high volume center is defined as a place that does at least 30 to 40 of these types of surgeries a year. And then it also focuses on shared decision-making between patients and the medical team, recognizing that you are the integral part of this conversation and how we are treating you. And so having a good conversation to figure out what to do is important. So focusing on Marfan syndrome specifically first, this is the first time guidelines actually recommended use of a medicine in preventing aneurysm dilation and dissection. And that was because there just wasn't good data until more recently to show that this does help. But there is data to show that use of medicines like beta blockers or angiotensin receptor blockers, those are medicines that usually will end in olol or sartan, so metoprolol, carvedilol, valsartan, losartan. There's a couple of different ones within each class of medicine. But they do recommend that we initiate these in patients and try to get them on as maximally tolerated doses as possible to reduce the risk of dissection. They recommend that we do at least annual imaging of the chest and the thoracic aorta. And then they generally recommend that surgery should be considered at a diameter of greater than or equal to 5 centimeters. If patients have specific features that are considered high risk, or if it's a younger woman who wants to get pregnant, we often reduce that to 4.5 centimeters. Pregnancy is a high risk time for women with aortopathy. There's higher rates of dissection and aneurysm growth, and so we often want to kind of take care of that before we say, yes, go ahead, try to get pregnant and have kids. Loeys-Dietz syndrome is a little bit different. It's genetic, it's a different genetic underlying mutation. The risk of aneurysms isn't necessarily just isolated in the aorta, but it's kind of throughout the whole body from head to pelvis. And so they still recommend use of those same medicines that we recommend for use in Marfan syndrome. Usually the timing of surgery is a little bit earlier for patients with Loeys-Dietz, and so it's usually between 4 and 4.5. And the decision depends on the patient's underlying specific genetic variant, how fast their aorta has been growing, what their family history is. So if you know you had a family member who dissected at 4.1 centimeters, we would be more aggressive at recommending surgery at lower thresholds, and then also the age and gender of the patient. And then we should be imaging Loeys-Dietz patients every 1 to 2 years from head to pelvis, given the risk of aneurysms throughout the whole body. And then last but not least is vascular Ehlers-Danlos. Unfortunately, there is still very little medical data out there to guide management in patients with vascular Ehlers-Danlos. And that's because it's just such a rare disease. And so these guidelines for vascular Ehlers-Danlos are actually based on expert opinion, because we don't have good enough studies to really help us figure out exactly right now what to do. So what we do know is the onset and severity of the disease will correspond to the individual genetic variant. So getting genetic testing and also understanding family history are important in assessing an individual's risk. Frequency of imaging surveillance is uncertain, but we generally say every 1 to 2 years, head to pelvis as well. Beta blockers are considered reasonable, but there is not great data to support that they are definitively beneficial. There is a drug that's under study right now called celiprolol. It's in phase 3 clinical trials, but we need that to be done before the FDA will approve it. So kind of needing more time to get that medicine. And then there's no real cutoff at which we say, this is the time for surgery. And that's because surgery is higher risk in this group because the vessels and skin are very fragile. So there's higher bleeding and surgical complications and wound healing complications in vascular Ehlers-Danlos patients. So we usually say if the aorta has grown rapidly, that's concerning. And then otherwise we reserve it for when the event occurs, which is often not very comforting for the patient. But unfortunately, that's just kind of where we are right now in terms of understanding the disease and understanding what's best for each person. So that was broad strokes overview of those guidelines, but happy to take more questions after this session. Thank you.
Thanks, Natasha. And guidelines are extremely important. It's certainly better than Dr. Google, and guidelines are written based on data. And thanks for that overview. We're going to make a slight change in the agenda here. We're going to be moving up the first talk of the next session to this session. And so it's my honor to introduce Dr. Subramaniam, who's the professor and chief of cardiac anesthesiology at Shadyside and Presbyterian Medical Center, and he's going to be talking about cardiac anesthesia. Thank you.
Anyhow, while slide is loading, as anesthesiologists, we always hide behind the screen and do most important things. It's good to come out and talk in front of patients. It feels very good. Thank you very much for the opportunity, the course directors and organizers. How do we move this? Is there okay. So anesthesiologists are focused on two important things. One is patient safety and the quality of care during and around the operation. That's called perioperative care. Preoperatively, during the operation, and also after the operation. When you come for a visit with cardiac surgeons, the cardiac surgeons decide to do an operation. They call us to see you to look for anything else other than the heart that we can optimize to improve outcome after surgery. Maybe it's something to do with lungs, maybe something to do with neurologic system. We look to preoperative testing and evaluation in detail. Some of the things we look for is anemia, protein deficiency, sleep apnea. If there is a smoking habit, stop smoking, and weight loss measures. If there is a massive obesity, we would like to reduce the weight to an acceptable limit to improve the outcomes after surgery. Also, we provide a lot of preoperative education so that you're not anxious when you come for surgery. The Marfan specific preoperative concerns are mainly respiratory. When you have a spine deformity and chest deformity, it provides some kind of restraints on the lungs. So we like to test the lungs by pulmonary function testing and optimize by pulmonary rehabilitation and bring you for the surgery so that you don't end up in ventilator in the ICU for a long time after surgery. And this is a kind of setup we do in the morning in the operating room. As anesthesiologists, we have a high incidence of speeding violations because we come in the early morning, 5:30 a.m. So I myself have a lot of tickets. So we come in the morning and basically try to fix the machine, try to set up the infusions, try to organize the medications, and then come and talk to you. So these are all the medications. Many of them are color-coded. The components of anesthesia include analgesia, which is the pain relief, amnesia and unconsciousness, that you are not aware of the surroundings, you are not aware of the operation, muscle relaxation so that the surgeon can operate without any stimulation. And then after all these things, when the surgery is over, the reversibility, that's also important. When you see that milky solution, that's called propofol. That's what we use for amnesia or unconsciousness. The red medication, what you see is the muscle relaxant, which is used to relax the muscles. And then the blue one is fentanyl, which is for analgesia or pain relief. So each medication has a role to play. Once we prepare the operating room and the medications, we come and see you in the preoperative holding area to explain everything again. To reduce anxiety, we place IV lines to administer medications. We also do something called arterial line to monitor your blood pressure. Blood pressure is the key for maintaining your circulation to the brain, circulation to the other parts of the body. So the blood pressure maintenance during and after the operation is taken care of by anesthesiologists. Once you come into the operating room, we give you some oxygen to breathe, and we instrument your airway to put a breathing tube in so that we can breathe for you. So that's called endotracheal tube, which goes through the vocal cords into the lungs to provide oxygenation. In Marfan's, there could be some component of the airway which may make this instrumentation difficult. So we look for those future, and we are well prepared to address those concerns. And that's the endotracheal tube I mentioned, which goes into the lungs and gives you oxygen, also the inhalation agents that's called isoflurane or sevoflurane, which provides anesthesia. They're all anesthetic gases. We also place something called central line in the main internal jugular vein in the neck. That's all happens after the patient goes to sleep. We scan the neck with the ultrasound, look for the vein, and place that central line so that we can monitor your pressures in the heart, also to administer important medication to keep the blood pressure up. We also monitor something called transesophageal echocardiogram. This is an ultrasound probe which goes through the esophagus. It is placed behind the heart in the foot tube to monitor heart, and that's the heart beating. We see this before and after the surgery is over to make sure the surgery is performed optimally and to know the quality of the result of the operation. We help the surgical team to see whether the heart is functioning okay, the valve is functioning okay, aortic rapport is perfect. We also monitor the vitals like oxygenation, blood pressure, central venous pressure, pulmonary artery pressure, everything during operation intensely and during the operation continuously. Brain, so the patients are asleep during the operation, so we also monitor brain by a number called BIS. If the BIS is 93, that means as you see in the screen, that means the patients are fully awake. What we aim for is somewhere between 40 and 60 so that we know the patients are nicely asleep and unconscious and not aware of the operation. We also monitor oxygenation in the brain through something called cerebral oximeter. That 67 and 65 are the numbers you see that provides an index of oxygenation of the brain. That means the brain blood flow is maintained during the operation. We work with specialty clinicians, perfusionists to facilitate cardiopulmonary bypass. The cardiopulmonary bypass is something which happens during heart surgery specifically. The blood is taken out of the heart. and pumps through a machine and comes back through the big blood vessels. Why it happens? We want to empty the heart during the operation. We also want to relax the heart completely so that the surgery can be performed without any disturbance in the field. So that is cardiopulmonary bypass. We work with the clinicians called perfusionists to facilitate cardiopulmonary bypass. We would like to keep the patients warm during and after surgery. We administer a lot of blood products. During the surgery, a lot of blood is lost. If the blood loss is excessive to drop the hemoglobin, we administer red blood cells. We also give some products like plasma, platelets, and cryoprecipitate to make sure that bleeding stops so that you can go safely out of the operating room into the ICU. So this is where you come to the operating room. When you go out of the operating room, a lot of instruments comes with the patients. But everything will be taken out in ICU safely. And that's the typical ICU setup. You have infusion pumps, you have monitors, you have an endotracheal tube which is connected to a ventilator. But as soon as, within 6 hours, the aim is to take out this breathing tube, breathe on wound within 6 hours of operation. So that is called extubation. We put the breathing tube during the operation and take it out after the operation is over. We would like to facilitate the post-operative recovery. At UPMC, we launched something called Enhanced Recovery After Cardiac Surgery Protocol, which is aimed at excellent post-operative pain relief, which you will hear something from my colleague Luca. We like to start feeding as early as possible. We would like to mobilize the patients as early as possible. The lines and tubes which we put in during surgery will be removed as early as possible within 24 to 48 hours. And all these things will help to get early discharge from the ICU, early discharge from the hospital. And keep calm, we are here for you.
Thanks for that overview. If I can ask the speakers to come up to the stage, and we'll open up for questions. And this is for you all. So I have a lot of questions, but it's you guys should go ahead and ask questions. And you can raise your hand, and somebody will bring over a mic if you have a question. None? Okay, here we go.
Oh, thank you. I have a question about genetic testing. I was diagnosed with Marfan's 35 years ago, and there wasn't genetic testing. I was diagnosed because my 33-year-old brother had an aortic aneurysm and died. And then we realized, when I found out about Marfan syndrome, that I had similar characteristics. So I had gone to Johns Hopkins and was diagnosed there. So I have never had genetic testing. So I'm wondering if it's valuable for me to have that. I do have a cardiac MRI. I did have it yearly, and now they said maybe every 2 years. My aorta is slightly enlarged, but not dangerously. And I do have, MVP, and I have, I've had a detached retina, I have eye problems, and I've had some bleeding problems when I've had surgery. So I'm going to turn 70 next week. So when they said, somebody said life expectancy was raised to 70, and I was like, oh. Do I need to have genetic testing? So that's my question.
Yeah, I'm glad to answer. I think it would be helpful to know, because there can be overlap in things that we thought were Marfan syndrome. Now I don't think we really knew about Loeys-Dietz and other related connective tissue diseases, probably when you were diagnosed. So I think it would be valuable to know, because there's changes in how we look. If it happened to be something that looked like Marfan syndrome but was truly like Loeys-Dietz, that would change what we would screen. and we'd need to look from your head down to your pelvis at the arteries there. And also to inform if your family members.
Yes, and since my brother's death, about 4 family members have been diagnosed. So, you know, it was heartbreaking when he died suddenly, but we feel that his death wasn't so much in vain because everybody else was diagnosed. I'm from Erie. Do I need to come here for genetic testing? Because I haven't heard of.
Sheila, we do have a clinic up in Erie. So for cardiology, I go up there, and so does pediatric cardiology. If you can't come up here, come down here, we can always have a video visit with a genetic counselor.
I'm sorry.
Video visit, and you meet with the genetic counselor. They go over the testing, and we can mail you a kit. There are 2 options. Blood is always preferred. And you can also do a saliva sample, or you can go to like the Hammett Medical Center and get your blood drawn, and you don't have to come back here. So a lot of this could be accomplished remotely.
Okay, because they finally did get the cardiac MRI machine in Erie, because I used to go to Johns Hopkins, then I came to Pittsburgh. Now I can just stay in Erie for that, so that's a good thing. Thank you.
Yeah, thank you for your question.
Dr. Singh?
Good morning. Mike Singh, Vascular Surgery. My question is about genetic testing as well, and I need a little better understanding. Your slide sets were spectacular, but the question that's often asked by my patients, first-generation relatives should be tested, but will it be covered by their insurance? And I honestly don't know the answer. Would you be able to enlighten me on that?
So if a person has a positive genetic test result through Invitae or GeneDx, the company there's a time limit associated with it. It's different per company, but for Invitae specifically, it's 150 days from a positive test. They will test a certain number of first-degree relatives. I think it's up to like 5 or 6 for free for that gene mutation. So if you have a very large family, it may not be covered by everybody, but once somebody else has another positive test, you can then use their benefit through Invitae and try to use it that way. But I do know it's somewhat hard for patients to navigate talking to these companies, and so that's where our genetic counselors are helpful in kind of facilitating getting that additional testing done through the company.
Jessica Sebastian is a genetic counselor here with us today, so an important person for everyone to know. A huge wealth of knowledge that has really supported our clinics. Yeah.
Here and one more there. Okay.
I was wondering, how many vascular aortic surgeries do you do here per year?
Dr. Singh or Dr. Sultan is right there. They can answer.
How many?
I have a I mean, it varies, but since in the adult world, obviously we have a very large, and maybe I'm speaking for, I'm a pediatric heart surgeon. We do obviously do aortic operation for Marfan's and other connective tissue disorders, children's, but you know, that one of the beauties of UPMC is that we're just not limited to one institution or one set of expertise. We have a combined group of people, as you can see here today, that involves from PD docs all the way to adult docs. And the combined experience, I was looking at the adult experience, and obviously we have tremendous experience dealing with aortic dilatation for 1,000 different reasons. So you'll see the numbers that I will put up when we look at the adult side, but since 2014, about a 9-year period, it was about over 400 patients that were treated for aortic issues. So it's quite extensive and a lot of experience as it relates to aortic issues here in the UPMC group.
Just to elaborate on that, so that's 400 patients who had valve-sparing replacements, and we follow between Dr. Cerna, Dr. Hoskbal, and the panel up there, Dr. Singh, myself, we followed approximately 1,200 patients with thoracic aortic disease. Most of these patients don't need surgery, thankfully, right? But the whole point that we stress on is, once you see as you establish a relationship, you can ask key questions, if I need surgery, what do I need? And our APPs will go over this. it's about plan A, plan B, plan C. And plan A is, you know what, let's hope you never need to have this. But what if you have chest pain? What if you go to the emergency room? How are you going to get routed to the best facility to take care of? When you look at, that's just aneurysmal disease. When you look at thoracic aortic dissections, which is where really the difference in morbidity or risk of death comes up, we typically do approximately anywhere between 55 to 70 type A aortic dissections a year take care of, okay? We see a few more patients than that, but not necessarily everyone's a candidate. You know, a 90-year-old person that comes in is not necessarily that candidate. And then when it comes to type B aortic dissections that we take care of together, that adds up probably another 50 to 60 a year. So it just gives you a perspective. Anything you want to add to that?
No,
Yes. Hi. I was wondering if there is currently any research being done or any role for gene therapy as treatment for patients with these disorders.
Not that I'm aware of. That's a great question, of particularly gene therapy, but there are certainly ongoing research projects and collaborations nationally looking at the care for these patients. I'm unaware of any true gene therapy. It's a great question. One day. Yeah.
Like, I have one last question, then we can break, and it's to Dr. Subramaniam. You know, you talked about pain control analgesia during the procedure. Can patients do something before they come in to alleviate anxiety related to the procedure, maybe even at home or, you know, leading up to the procedure?
Yeah, that's a great question. I think most important thing causing anxiety is not aware of what happens around the operation. So that's the whole purpose of having a preoperative clinic, so that we sit with the patients and talk to them. Okay, this is what happens when you come for surgery. You know, before surgery, during surgery, after surgery, we explain step by step. That's a single intervention which prevents anxiety in patients. So they know what is going to happen. That relieves their anxiety. But we can use some medications if the anxiety is severe enough. So something called benzodiazepines we can use. Typically, we don't prescribe them for the patients before surgery, but before going to the operating room, we give a small dose of midazolam to reduce anxiety. That helps patients a lot.
Thank you. I think we do have one more question, and then we can take a break. Time.
I just want to tell you how grateful I am for this hospital. You already saved my daughter's life once. I wouldn't want her to be in anybody else's hands. I'm so grateful for you guys, and my mind is blown that this support group has been here for 42 years. I have spent half my life in hospitals with her, with orthopedics, and nobody, anybody's never mentioned the word Marfans until she was here when a learning team came in and they seen the way her feet rested. I had her to the vet for orthopedics. Nobody ever said it to me until they came in and they looked and they said to me, have you ever had her tested for Marfans? My dad died at 37 years old and they knew nothing about it. She had her aneurysm at 37 years old. Drove herself here and they saved her life. And I just want to thank you all for what you do. I'm so glad to be here. Got a big surgery coming up, and this is very educational. Thank you all.
Thank you.
All right, good morning. I'm Michael Singh. I'm a vascular surgeon here at UPMC and one member of an outstanding group of specialists that work within this realm of complex aortic pathology. And without further ado, I'd like to introduce one of my colleagues and a good friend, Dr. Derek Cerna-Gallegos, who's one of our outstanding cardiac surgeons who's primarily based at Presbyterian Hospital. He's going to discuss thoracic aortic surgery, which actually is going to complement the talk that Dr. Vic Morell and Dr. I will be giving shortly thereafter. So without further ado, here's Derek.
Hi, thanks a lot to everybody who put on this symposium today, especially Dr. Sultan, Dr. Singh, Dr. Hoskapal, also Angie, we got to give her a lot of credit, and the Marfan Foundation, and most of all to all the families that came out today and are willing to share their stories and come meet us and get to know us. And you know, all of us are looking forward to the event this afternoon too. I mean, not everybody's able to stand up in a large group and ask a question. And that's why this event this afternoon will be great, because I'm looking forward to getting to know all you guys and you know, answering any questions that you know, come up between now and then. I have 2 little kids, so just look for the commotion and you'll find me. So what we're going to talk about today, the topic was pretty broad: thoracic aortic surgery and connective tissue disease. And we're going to kind of go over the 5 W's. We're going to talk about what is thoracic aortic surgery, why patients should get surgery, who should get surgery, when they should get surgery, and where they should get surgery. And a lot of the things we'll talk about today will overlap with other talks you're going to see and other talks that you already have seen, looking at guidelines and things like that. So to start, what is thoracic aortic surgery? Well, the aorta in some way is replaced or stabilized. Now, the top picture there is a graph that we use, and often patients will ask, well, what do you replace the aorta with? What do you do with it? And that is a polyester material. It's called Dacron, and we use it. We suture it in place to take out or to take the place of the aorta, which is aneurysmal. There are also endovascular stents, like you see below, that is material supported with a metal scaffolding. We'll talk shortly about whether that's an option in some patients. So aneurysms can affect any part of the aorta. Generally, in the patients that we're talking about today, connective tissue diseases more often in the aortic root, ascending aorta. And what we know from other talks we've done today is that patients are younger and often have faster growth when we're talking about connective tissue disease. Now, whether that's Marfan's, Loeys-Dietz, or Ehlers-Danlos. Now, as I mentioned before, is endovascular repair an option in patients with connective tissue disease? And that often comes up because nobody wants to get an open heart surgery if they can have a stent put in through the groin, right? And the kind of philosophy of endovascular therapy is that you're relying on that scaffolding to give radial pressure to the aorta in a normal area that's not aneurysmal. Now, we know that in patients that have connective tissue disease, even if it's not the part of the aneurysm, that aorta, that blood vessel, is not normal. And so in many situations, we try not to use endovascular stents because we don't know exactly how they're going to perform. There's been studies that have looked and seen, you know, increased complications, but in some situations where there's a surgical graft on one end and another surgical graft on the other end, it can make sense to use an endovascular graft where that radial force is not being pushed on the aorta, but is being placed on a previously placed surgical graft. So there are situations, but uncommon. These are the same guidelines that Dr. Wolf had mentioned before. I think it is good that you guys are able to see these. It's a quick Google search of aortic guidelines 2022, and this will come up. It can answer many of the questions that you have. So why should we get surgery? And I talk to patients about this often in clinic. So the surgery of an aneurysm really is preventative surgery, okay? There are situations where it affects the valve, the aortic valve, if the aneurysm is in the root, causing leakage of that aortic valve, or in patients who have connective tissue disease who have mitral valve prolapse, as was mentioned in the previous presentations also. But unless there's valvular involvement leading to things like heart failure, symptoms like shortness of breath, in general, and what I tell patients is this operation is not going to make you feel better. Okay, now if there's a valve that's involved causing heart failure, shortness of breath, buildup of fluid, then yes, you will feel better afterwards. But aneurysm surgery as a whole really is preventative surgery. And what are we trying to prevent? We're trying to prevent catastrophes, things like aortic dissection, aortic rupture, intramural hematomas, which is kind of a variant of aortic dissection. So It's important that patients know, the goals of the operation. The goal of the operation is not to make you necessarily feel better. It's to prevent some catastrophe from happening in the future. And again, the caveat of that is unless there's valvular disease causing heart failure symptoms. Who and when? So we talked a little bit about this. This is just kind of a general. So Marfan syndrome, greater than or equal to 5 centimeters for any part of the aorta, unless we have some of those high-risk features. High-risk features are, rapid growth of more than 3 millimeters in a year. Okay, family history, tortuosity, as was shown, kind of like the curlicue nature of the vessels. Those are things that could make us operate or lean towards operating earlier. Loeys-Dietz, between 4 and 4.5, as we talked about before, depending on genetic variants. And vascular EDS, again, and this is kind of a reinforcement of previous stuff. There's no data to drive recommendations. Again, we want to involve shared decision-making of the patient, look at each patient as an individual. Multidisciplinary aortic teams are key, and that is one thing that no matter where you end up getting any care that you need, whether it's here or another institution, that is something that is, I would say you have to have, okay? And you don't want to be cared for by one single doctor, okay? We're all great. We all, think we're the best in the world, right? But we know that as long as there's more perspectives involved, a cardiologist, geneticist, vascular surgeon, cardiac surgeon, all these people really bring something different to the table. And if we're going to really provide you with the best care possible, that's really the only way to do it. And that kind of leads into this next thing. So where should I get surgery? Well, two ways to look at this. The literal situation is, well, wherever the aneurysm is located, okay? The other part of it is the institutional perspective, as I'm talking about. So these are just some quick questions from the first literal part of the question. So this is an aortic root replacement. You can see the valve down at the bottom. Here, we have to reimplant the coronary arteries, and that the aortic root involves the aortic valve, as well as all the tissue around the aortic valve. Now, it doesn't always require a replacement of the valve in this situation. I didn't include anything else because Dr. Morell is going to go into more detail on that situation. Here's a replacement of just the ascending aorta. You can see that the root where the coronary arteries come off and the valve is left alone, and the ascending aorta is replaced. This is a drawing of a replacement of the arch of the aorta and the blood vessels that go to the brain and the bilateral arms, bilateral upper extremities. And then this is just variations of replacements of the rest of the aorta. And that's basically from the arch involving, the blood vessels that supply the abdominal viscera, so the kidneys, the liver, the intestines, all the way down to where it splits to go to the legs. Now, where should I get surgery? The other part of that question is we kind of consider it to be aortic centers of excellence. Now, this comes from the idea of a National Cancer Institute designated cancer center. So we don't have the exact same thing for aorta, but it's the same idea. So the National Cancer Institute recognizes centers around the country that meet very rigorous standards, transdisciplinary, state-of-the-art research, and places that are dedicated to care of patients with cancer. We take the same kind of theory and apply it to aortic surgery and aortic, patients with aortic disease. So you want to be somewhere, and frankly, I would say demand to be somewhere where there's a multidisciplinary team, multiple teams following patients, multiple perspectives, and multiple eyes on the same problem. Shared decision-making, a place that's not going to just tell you this is what you need to do, don't ask any questions, don't say anything else. This is the one choice you have. You don't want to be at a place like that. Every patient's an individual, and every situation is an individual situation. And the last thing is high surgical volume, which was mentioned before. This was a study from Yale University looking at surgical volume for proximal aortic surgery, so aortic root, ascending aorta. And the red line is actual mortality, so percentage of patients that died. Blue is predicted risk of mortality, expected patients. Unfortunately, these diseases are so dangerous that there is they can calculate an expected mortality for these cases. And then the gray is the ratio. So you can see at the bottom as the number of cases goes from 5 to 5 to 10 to 10 to 20, 20 to 50, and greater than 50, you can see that actual mortality drops significantly as the predicted mortality stays about the same. So we know that the more of these operations we do as surgeons, and the more of these operations the hospital sees, not just the surgery, because the surgery is the first step, right? So the surgery means, is the first 4 or 5 hours of the patient's situation in the hospital. The rest of it is critical care medicine. All of our advanced care practitioners who take care of these patients with us on the floor of the ICU, some of them who you'll hear from today, but the entire hospital system taking care of lots of these patients. That's really what's important. And just a quick review of all these W's we talked about. So what is it? It's just replacement of the affected aorta. Why? Reduce the risk of aortic catastrophes. We're talking about aortic dissections, aortic ruptures, other things that don't necessarily lead to death, but can make the recovery and everything else more complicated, okay? So the goal, and I was just talking to Dr. Hoskell about this, is that the goal is this. The goal is medical management until you need surgery. If you don't need surgery, you don't need surgery, right, throughout your life. But medical management until you need surgery, and it's a goal, but not ever having an aortic catastrophe, never having an aortic dissection, because we got to it before it got to that point. So that's kind of in a perfect world, but that is really what we strive for. And that's why, we have so many different specialists watching over all of you and all of our patients. So when we talked about that, 5 centimeters in general, in some cases 4 to 5, depending on the disease and the genetic characteristics, and then where experienced centers. So this is my contact info. Feel free to email me directly. I'm happy to talk with anybody this afternoon, answer any questions, and just want to thank everybody again.
I'd like to welcome Dr. Victor Morel to the podium. Vic wears a lot of hats for UPMC. He's the chairman of cardiothoracic surgery, director of the Heart and Vascular Institute for UPMC, and chief of pediatric cardiac surgery at Children's Hospital. Incredibly gifted surgeon, and I'll tell you a secret, he's one of the nicest guys you're ever going to meet. So Vic, welcome to the podium.
Thank you. Thank you. Thank you, Mike. Thank you. Well, it's a real pleasure being here with you all. I think this is a great event. I think we're so happy partnering with the Marfan Foundation. This is I think for a lot of us who work a lot in the aorta, this is an incredible topic and something that I think you can see my slides are a little different. They don't have the black background. They have a very nice children's-like background. And that goes to show, what we do here in UPMC. We hear stories about patients who get diagnosed at much later ages. We have the ability to identify these patients early on as children. There was at least one child around who I had a chance to touch early on in his life. So it is really a really neat place to be, and the expertise goes from, again, children's to adults, and this is really the life you guys live. It's from children's to adult, and not just an adult life. So that continuum of care is crucial for, I think, the well-being of patients with connective tissue disorders. With that said, I'm just going to describe the evolution of surgical techniques involved in the management of dilated aortic root, talk very superficially about outcomes and just our experience. In 1968, Hugh Benthal, and we call it the Benthal procedure, was described, in which he basically took a tube that had made out of Teflon with a valve on it, and he replaced the aortic root on a patient. And that's what we call the Benthal procedure. And this is basically how it looks. You have a mechanical valve in the aortic position. You re-implant the coronary arteries. You end up with a mechanical replacement of the aortic valve, which is not necessarily ideal in the sense you're going to be put on a blood thinner for life. So, but it certainly is a great operation and it works very well. And certainly there are plenty of patients out there with a bent-off procedure. And we certainly performed that operation. Then in 1992, Tyrone David came with what is known as a David procedure, but it's really valve-sparing root procedure. You can see that out of the initial 10 patients that he presented, about half of them had Marfans. And this is usually how an aortic root looks like, and I have a little movie I'll show you. And you basically excise all that tissue and preserve the aortic valve. The aortic valve is surprising that in most patients, especially without dissection, the aortic valve looks pretty good and usually works pretty well. And you end up putting the aortic root inside a tube, okay, then suture it into the tube so that the aortic valve sits inside a tube, and then you reimplant the coronary arteries. This is basically how it looks. You take out the aneurysm, the coronary arteries are separated, you have the aortic valve, you put it inside a tube, you suture inside the tube, and you end up with your own valve, coronaries get reattached, and you don't need to be in Coumadin for life. Then Dr. Yacoub came with what's called the remodeling aortic valve type surgery, in which you don't put the aortic valve inside a tube, you basically suture it to a tube like here. So the valve does not sit inside a tube, okay? And this is what we call the Yacoub procedure. There's another technique that recently, more recently in 2005, which is known as the Florida sleeve, in which you basically put the root inside a tube, so it's like a sleeve. You don't have to detach the coronaries, you leave the coronaries attached, and you just put it like inside this tube. So even if it dilates, it's only going to dilate to a certain level, okay, because it's inside a man-made tube. And this is, you basically cut the tube so that you can fit it around the coronaries, you resuture it, you stabilize the aortic annulus so it won't dilate, okay? So we have different surgical techniques, and I think it's important as surgeons for us to know these techniques, and because at times some patients might benefit from one technique, or you could do 2 or 3 of these techniques in the same patient, and you have to make a choice. What are you gonna do? Sometimes it's based on what you do more often, what you do well, what you feel comfortable doing, okay? And the results of these operations are somewhat similar, okay? So it's good to know. What happens when we have a patient that has an aneurysm and has an abnormal aortic valve? I think most surgeons out there will replace the aortic valve, okay? Especially in a patient with connective tissue disorder, because there's always the concern that that abnormal valve will come back to haunt us a month later, 2 months later, 3 months later, okay? Maybe 1 year later. We don't want patients to come back often to see us as surgeons. I think for you guys, it's better if you stay away from us, see us once, and then hopefully that's the last time you see us. But there are some techniques that can be utilized for patients with Marfan's and other type of connective tissue disorders that are relatively simple techniques to fix, for example, a prolapsing valve. Like here, you're basically suturing a Gore-Tex, making this valve leaflet here a little sturdier and smaller. This is another technique in which you have a prolapsing valve that is too long compared to the other two, and you can just make it a little smaller. We just recently did this on a child that had aortic insufficiency for a different reason, but it works very well. This is a recent patient of mine. You can see the aortic aneurysm. You can see the aortic valve inside the aneurysm. The aortic valve looks good. Even though the patient had some aortic insufficiency, we thought that the valve was good and we can preserve it. Here you can see we're doing a David operation. We get rid of the excess aortic wall. You can just see the valve. Here, the sutures below the annulus of the aortic valve has been sewn to the tube. You can see here the Dacron tube. You see the valve sitting in there. Leaflets look good. Now it's been sutured circumferentially to the tube so that the valve on test looks good. The left main coronary artery has been sutured into the hemoshield tube here. You can see the left main here. The right coronary is here. It's also reattached. You can see operations finished. This patient also needed a replacement of the pulmonary. But, you know, so it's a technically challenging operations, but for centers and for surgeons who do it often, you know, it's a very enjoyable operation, I have to tell you, especially, you know, it's very reproducible and gives great results. It's interesting when you look at what's happened historically since 1968 when the Bentall procedure was described. You can see the initial reports of patients, you know, up to, you know, 2000. Initially, most patients just got a Bentall. Nobody was doing valve-sparing routes. And as time went on and the procedures got described and surgeons started using these surgical techniques, now you rarely see anybody doing a Bentall. You see most of us just doing some type of either Yakub, Florida sleeve, or David operation. This is a recent article in which Ibrahim Sultan was one of the, and Dr. Serna Gallegos participated in University of Pittsburgh along with others, describing a meta-analysis on comparing the Bentall procedure versus the valve-sparing route and long-term outlook and survival. And you can see that there was an advantage to the valve-sparing route compared to the Bentall in long-term survival and lower risk of need of reoperation in these patients. So there appears to be an advantage to valve-sparing routes compared to the Bentall. There are times you have no choice, though. If that aortic valve can be saved, it can be saved. You have to do a Bentall. So, but if you have the option, maybe doing a valve-sparing route is better for patients. And you know, there's always the question is, at times we do valve-sparing routes in patients who do not have connective tissue disorder. We're not doing it because they have Marfan's or Louis Dietz, or we're doing it for some other reason. And is having a connective tissue disorder, is it a disadvantage for the valve-sparing route when you compare these two patients with Marfan's versus patients with no Marfan's, and the outcomes are similar. So it does not appear to affect the aortic valve. When you do a valve-sparing route, it gives you the same results. And like we mentioned before, this is, I asked our data person at our Heart Institute to put this together, and you can see since 2014 to 2023, a significant number of patients who come through our doors to undergo valve-sparing routes, aortic root surgeries, quite a few. Anyway, it's been a pleasure. Thank you so much.
You already know who I am. I'm up next. Here we go. So this presentation is actually complementary to everything that you've heard so far. Our surgeons, our cardiologists are doing an amazing job. And what's going on is that we're shifting the pathology downstream so that the abdominal aorta and the blood vessels within the abdomen and legs are now our area of concern. So with the aortopathies that we've talked about, I'm going to address all three today. But the bottom line is preventative medicine is critically important, and prophylactic surgery will hopefully prevent something that we could run into, which is a catastrophic rupture where the blood vessel basically blows up. And the analogy would be a water balloon filled with water. If that water balloon expands too much, you know what's going to happen. It's going to burst and the water hits the ground. So looking at Marfan syndrome, we know a lot about it today. The cardinal manifestations you've already heard about: involvement of the aortic root in the ascending aorta. We've done a really good job improving the diagnostic studies, medical therapy, replacing the root when indicated, modifying lifestyle. And what's happened? We've extended our life expectancy. So that's good news. That's what we want. And what we now acknowledge is that after root replacement, after addressing the type A dissections, that about 10% of patients end up having a dissection involving the thoracic aorta going down. 10 to 12% will have involvement of the abdominal aorta or the blood vessels going down to the legs called the iliac arteries. And somewhere over 20% will have a combination of both the aorta within the chest and the abdomen involved. And when you look at this series of 300 patients who underwent vascular repair, 78% had involvement of the thoracic aorta, which is what Dr. Derek Cerno-Gallegos presented earlier, and the abdominal aorta, which we're going to address now. So an aneurysm's an aneurysm, an aneurysm, except when you're dealing with connective tissue disorders. What we can say is that for people who do not have a syndromic problem, 80% of aneurysms involve the abdominal aorta, those located below the renal arteries, involving the renal arteries, or subtly above it. And with that being the case, the guidelines are consistent. Women, we tend to fix at 5 centimeters, men 5.5 centimeters. What we can say with Marfan syndrome is that the guidelines have stated, obviously we're looking at an absolute objective number. What we're going to safely say is that if you have an aneurysm of 50 millimeters or greater, we should probably address it. And that's prophylactically. So many of you are going to say, well, what the heck is 5 centimeters? Well, it's bigger than a bean, it's larger than a peanut, almost the size of a walnut. But if you go to the grocery store and pick up a lime and put it in your palm, that's about 5 centimeters. So that's what we're looking at when it comes to fixing a blood vessel, the size of a lime. I used to use a baseball as an analogy. Baseball is 7 centimeters, so a little bit bigger. So here's a picture. It's a little gory, a little crazy, but to make a long story short, it validates the point why you've got to build a team and why you have to work together. These complex problems involving degeneration of the thoracic aorta, the abdominal aorta, the branch vessels, long, complex, time-consuming operative procedures, increased morbidity and mortality, but it's not uncommon. The majority of patients who have Marfan syndrome, when they do have some type of involvement of the thoracic aorta or the abdominal aorta, will have an extension like this, necessitating a very complex surgical repair, which is typically done based on a strong team of physicians, both cardiac surgery and vascular surgery. Now, where do we come involved? Well, something is pretty interesting. After a major surgical procedure to repair the aorta, it's unfortunate, but about 90% of the cases, we're going to notice there's ongoing degeneration focused on the remnant of the aorta that was left behind. This is called an inclusion patch. And with that being the case, it's a portion of the aorta that may supply blood to the spinal cord or may supply blood to the visceral vessels, which is typically the arteries that supply blood to the liver, spleen, stomach, intestines, and maybe a kidney. And with that being the case, because we're dealing with an anomaly, the deterioration of the aortic tissue is not uncommon. And somewhere around 6 years, 6.5 years out, we'll notice that some of that native tissue may start to degenerate. And with that, a redo operation may be considered, but we'll acknowledge the first operation is tough in its own right. A second one, far more challenging, so the risks associated a little bit higher. So what can I tell you about one of those sexy, minimally invasive techniques that is often discussed and has been presented worldwide? It's on the USA Today front page and the New York Times front page. Long story short, these minimally invasive techniques with balloons and stents have not been studied. All of the major clinical trials purposely excluded anyone with a connective tissue disorder. And as Derek mentioned, it's due to the fact we're assuming that there is some type of inherent damage because of friction and outward radial force that is going to degenerate the native blood vessel, either at the top or the bottom. And the results from single center experience, really sobering. When you do put one of these devices in, it tends to degenerate the native aortic wall, and that these devices fail in 25 to 44% of cases. So that really is problematic. As noted before, there are a few exceptions. So if you've got a hand-sewn graft at the top and the bottom, I'm okay connecting it with one of these minimally invasive techniques. Or if it's a complex redo operation, we might think about this as a less invasive option to minimize the potential for adverse events afterwards. Well, let's shift gears. Vascular Ehlers-Danlos syndrome. Really nice picture on the right-hand side. The most important message is the vascular fragility. No question about it. It does shorten the life expectancy. Major complications occur by 20 years, significant number by 40 years, and the clinical manifestation, a little bit different than we've seen with Marfan's. More often than not, it's the medium-sized vessel. So if the aorta is a garden hose, the medium-sized vessels are kind of like McDonald's straws. That's the diameter. And these are the arteries which are branches off the aorta. And they unfortunately are susceptible to rupture, dissection, and pretty much all the blood vessels from the head down to the toes are fair game when it comes to this. And this representation, the schematic on the right-hand side of 24 patients, really shows you pretty much all the vessels emanating off the aorta have been involved with some type of degenerative disease process. I share this with you primarily because this is one of the technical challenges that we have as surgeons, is the fragility of the vessel. Now, the best way I can describe that is think about wet tissue paper. That's basically what the blood vessels are like. And you can imagine trying to put a needle or a stitch through that very thin paper. It's going to tear very easily, especially individuals who are a little bit younger where the disease process is a little more aggressive. If you look at fragility and bleeding and adverse events related to them, interestingly enough, it's the presenting feature in 70% of adults that do have this. So it's important to be cognizant. It's something that we're going to see throughout the lifetime of the patient. The technical challenges, no question, they're formidable and really requires meticulous technique. In some situations, we might want to just tie off the blood vessel with something called an umbilical tape. In other situations, we're not able to do so because it's a vitally important blood vessel. So direct arterial reconstruction requires a couple of things. Making sure there's no tension. We don't want to stretch it like a rubber band. We use extra material to reinforce the blood vessel wall called a pledget. We'll then wrap it. It's kind of like your garden hose. If you inadvertently cut your garden hose, you can wrap some tape around that. Same thing. We'll do something similar just to reinforce and prevent that from bleeding. We'll use softened clamps so they don't disrupt the artery. And then we sometimes, in conjunction with the anesthesia team, will utilize what's called permissive hypotension. We allow the blood pressure to go down a little bit more than we typically would, just to make sure we don't stress our suture line at the time of completing it. Something really fascinating about Ehlers-Danlos syndrome is the configuration. They end up having these dilated or bell-bottom iliac arteries, very unique pathology to that cohort of patients. And with that being the case, as Derek mentioned, there's no clear data on the diameter threshold for repair. We fully acknowledge that there's a high incidence of dissections and ruptures occurring at smaller sizes, and thus it's critically important to recognize a multidisciplinary team approach with shared decision-making is critically important when it comes to deciding, do we treat this medically or do we think about a prophylactic surgical intervention? Some individuals with severe phenotypic features, early onset, and prior complicated medical history may be better off waiting until a little bit later in the time frame, if at all. So another one, angiography. This is that minimally invasive technique we talked about before. We have to be cognizant. All the blood vessels are very susceptible to manipulation. So in this situation, if we decide to do one of these procedures, we are going to make a little incision, repair the artery directly with the same type of technique I described before with some felt to secure it, and then wrapping it with another type of material to make sure that it doesn't degenerate over time. And it does give us an option that we may not have with an open surgical repair. Here's a 28-year-old female, 10 days postpartum, spontaneous internal carotid artery aneurysm, grew very rapidly, became symptomatic, and this is something that was successfully treated with a metal stent and also what we call coil embolization. And these are little coils that look like a pigtail, and they go inside the vessel and fill up the sac. Here's an individual we treated at UPMC. It's a 38-year-old male with hepatic artery aneurysm, and you can see that big white circle like a golf ball in the middle of the liver. That's the aneurysm, and that was successfully treated with coil embolization. So there is a role selectively for treating patients with this minimally invasive technique. As we switch over to Lowy Dietz, I think it's important to recognize that arterial tortuosity and aneurysmal degeneration is common in just about everyone. And from that, the cardiovascular involvement is the hallmark of Lowy Dietz. Aneurysms occur from the root through all the branch vessels, as you can see within the schematic. Looking at the abdominal aorta and the branches, interestingly noted, over 17%, but when you calculate the distal thoracic aorta all the way down to the legs, it's 65%, so it's a big number. And we'll acknowledge rapid expansion in the native vessel is not uncommon, and dissections and aneurysms are not uncommon at earlier time frame and smaller diameters. Now, the vessels are less fragile than Ehlers-Danlos syndrome, and in turn, the tissue handling is more favorable. There remains somewhat limited information when it comes to when do we repair from a prophylactic perspective, but I think what we can safely surmise is that if you do have peripheral aneurysms in the iliacs, the femorals, we're probably okay thinking about prophylactic repairing them when the diameter is 2, maybe 3 times the normal size. And when we look at the abdominal aorta, which is the one right behind the belly button, or the thoracic aorta, there are criteria somewhere between 4.2 and 4.6 centimeters for elective repair. So I put everything together in a summary, and you can just focus on the aorta because that really was the talk I'm giving today. So for people with Marfan, we typically think about greater than 50 millimeters or rapid expansion. Lowy Dietz, 4.6 to 4.2, similarly rapid expansion. And for vascular EDS, I'm going to refer to the upper box. There's no data on the diameter threshold. You definitely need to have a team-based approach with shared decision-making, but we suspect because of the potential for adverse events at a smaller diameter, we might want to think about intervening when we double the size and a dilation occurs in that scenario. So in conclusion, aortopathies are frequently involving the aortic root and ascenic aorta. Because of the great job that we're doing, we're improving longevity. And with that being the case, we're finding more of the disease processes migrating downstream. Improvements of surgical technique, prophylactic elective repair have reduced adverse events and will utilize minimally invasive endovascular therapy in a limited role in a select number of patients. Thank you. Our next speaker, let's see, Dr. Mario Castro Medina will be joining us to talk about pectus repair. Wonderful. So that will be a recorded presentation.
Good afternoon, everybody. My name is Dr. Mario Castro. I work at Children's Hospital of Pittsburgh. I want to tell the Marfan Foundation for the invitation for the participation in this talk about the pectus management in all these patients with the arthropathies. So first, I would like to outline what we're going to review. Basically, we're going to review what are the most common chest wall deformities and the implications of the chest wall deformity during the aortic surgery. Like everybody know, the most common chest wall deformity is the pectus excavatum, what they call the funnel chest, the pectus carinatum, the pigeon chest, and it's around 0.8% in the general population. On the Marfan syndrome, they can have at 70% of the accompanied with this malformation. And there's a lot of morbidity on this and also a psychological distress in this chest wall deformation because the appearance of the patient, but also the repercussions on the physical activity on these patients. That's why it's so important always to consider the repair for the pectus excavatum. The orthopathies, like we know, is the Marfan syndrome, Ehlers-Danlos syndrome, Loeys Dietz, and they have a skeletal disorder, skin disorders, and also a vascular disorder in these patients. The pectus excavatum is the most common chest wall deformity. It's more predominant in male. It's approximately on 90% of the chest wall deformity is the pectus excavatum. And we need to remember that scoliosis is present in the 20 to 30% of these patients, like significant scoliosis. We see it a lot of these pectus, there's a chest wall asymmetry, and also there's a scoliosis. So that's always in a consideration in these patients. The symptoms, as we know, shortness of breath, exercise intolerance, chest pain, or orthostatic hypotension. And that's, I would say that this is the most common symptoms in the adult females having a pectus excavatum, tachycardia, and progression of the deformity during the puberty. Also, the poor body image that they reflect some of these patients. Diagnosis is basically, first we need to do a history and physical examination, and known about family history, also exercise tolerant tests, image study, CT scan, cardiac MRI, and echocardiogram. Nowadays, most of the exercise tests or pulmonary function tests, they are always on the lower side of the studies. The cardiac MRI is pretty useful because you can evaluate the function of the heart, also the relationship between the heart and the chest wall. So that's it's like a double play. You have the function of the heart, and also you can have the Haller index, and also you can manage and see what is the diameter of the aorta and the great vessels. The workout, usually we send everybody for physical therapy for posture evaluation. That's very important. Some of these patients, lately we see in a lot of psychological components like anxiety in some of the younger patients. Allergies, we always test for a metal allergy, but we need to know, as you can see, this is the new Pectus trail that is titanium nowadays. So the allergy test is much less. Sorry. And also some of these patients, sometimes we consider that they have a component of Marfan syndrome. We always send them for a genetic evaluation and the regular pre-op labs like H&H and coagulation profile. Surgical indication, as you guys nowadays know, what we always look is for the Haller index, more than 3.25. It's what we consider a surgical candidate. Usually all these kids with a Marfan syndrome or Lloyd's Dietz, they have more severe pectus than the 3.2. And at this time, usually, sometimes some of these kids, they have asymmetry on the chest wall, and also we evaluate the cardiac compression. As you see, when we do the Haller index, is the measure between the anterior posterior diameter and the lateral diameter, so we can get the Haller index. And also at the time of evaluation, it's really important to see how much is the heart compression of the right ventricle and the displacement of the mediastinum. Also, other thing to consider is always the chest wall asymmetry, and that also can have a important relationship with the scoliosis. Now, for the surgical procedure, as you know, in the late years, we've been changing the way we do the pectus. We do the nose procedure, and some of these kids, they need combined procedure, the ravage procedure and the nose procedure, and we do the minimal invasive procedure. That's meaning through the camera we look at. Nowadays, we do the cryoablation for every patient. So we ablate from the third intercostal space through the eighth intercostal space to freeze the ribs, and that's what give us a better pain control in the post-op. There's always the elevation maneuver. Basically, we use a rule track that was developed to procure the mammary pedicle for the coronary bypass, and usually we do this elevation maneuver, and at that time create a space between the posterior sternum and the mediastinal structure, so we can create a window so we can place of the nose bar. Now we use the Lawrence bar to create the track that we're gonna put the bar, and at that time we use the Lawrence bar. There's the remodelation of the chest wall. Once we have the remodelation of the chest wall, we basically position the bar, and we, at this moment, we always reinforce on the lateral stitches with the fiber tape of the bar to the chest wall. And that's how we usually fix the bar. This is what they call the Hammond stitches. And this is the most common practice when we do the collagen tissue disorder kids, when we do this pectus surgery. And what about the chest wall and aortic procedures? What is in the literature and what we're gonna find? And there's a few papers about doing the pectus excavatum with the combined procedure. All of these patients, they have a high Haller index, as we can see in these slides. And it's not uncommon because they have these deformities of the chest wall. Also, you can see the age of these patients can go from teenagers to adults or 52 years old. And the most common operations are aortic valve replacement or ascending aorta procedures. Usually the surgical technique is first do the surgery, the median sternotomy, do the heart procedure, and after that we can do the reconstruction of the chest wall using a nose bar, and most of this time we use a combined procedure. You can see in these different patients, the follow-up basically, it's not that long, it's in the first years, so the first years of life, and they did pretty well. Now there's another big review that they review all the literature and basically all the studies that they discuss about the Marfan syndrome patients and a concomitant aortic surgery, and you can see there's a totally of these between 39 patients. In those studies, they include 27 patients. The Haller index was around 9.2. The mean aortic diameter was 57 millimeters. So you can see that they have a real indication for aortic root replacement. And you can see in this study, they usually, from the 39 patients, 21 were median sternotomy. You can see 3 of them, they were transverse sternotomy. And then most of these, they did a combined procedure between the nose procedure using a bar and a ravage procedure. You can see that this is the cannulation details. Most of them, they were femoral vessels cannulated. Some of them were chest cannulation. And there's a case they use the right axillary artery and the right atrium. And you see from this, they use a combined procedure, that it's a nose procedure with ravage procedure. It means using the nose bar and doing the remodeling in the cartilage with the ravage technique. And I think for the adult patient, this is the procedure that you need to go. We need to do the remodeling of the chest wall and also the ravage procedure. And you can see that also the other thing is do first the aortic procedure and then the stage procedure. That is also another way to fix these problems. Now, in the last 10 years, we look at our experience at the Children's Hospital of Pittsburgh, and I can say in the last few years, we've been getting more referrals for pectus excavatum. In the last year, we've been doing more adults. And a few things I think changed the game. One thing is the new pectus trial, the titanium pectus makes more easy. There are prevented bars. Second one, we use the cryotherapy for pain, the cryoablation, and they do patient much better. And lately, we've been doing at least 2 adults that we've been doing combined procedure. We did the ravage procedure and the nose procedure, and we have one patient that was a previous aortic surgery and one patient who has previous coronary and roofing that we did a pectus after those operations. And we did one patient that was a Ehlers-Danlos disease that Dr. De Silva did a tricuspid valve repair. And after finishing the procedure, when we closed the chest, we did a ravage procedure. In this case, he was very skin Ehlers-Danlos, and he was so worried that having metal. So that's why we only did not combine nose with the ravage. We only did the ravage. And those are the operations that, we're getting more involved in the last year. And this is the case that was a previous aortic valve sparing on a teenager done by Dr. Morel, and the patient came back, and we did the modifying nose with the ravage procedure. We basically put the nose bar, do the elevation maneuver, dissect the back wall, and we did the ravage technique in the anterior part to remodeling the cartilage. And you can see this is a post-op CT scan, that this is the result that we have for this patient. So I will tell you that in the last year, our pectus practice at Children's Hospital of Pittsburgh is getting bigger. And I think probably we got more referrals from this pediatric population. And also the families, they're more well-informed. So they're bringing a little bit the kids early for our opinion for the pectus excavatum. So you can see the results, it's pretty good in some of these patients. They feel happy. And it's still a big operation that, to recover the chest wall. So thank you so much for the Marfan Foundation for the invitation for this talk. And I hope next year I can be in person in Pittsburgh. Thank you.
All right, I'd like to invite Dr. Luca Lacala to the podium. He's probably going to give us the most important presentation today, because we've told you that we can do this surgical procedure, but now I want you to know how we can make you comfortable and relatively pain-free following thereafter. So Luca, welcome.
Thank you. Thank you, Dr. Singh. Hello, everybody. My name is Luca Lacala. I'm one of the anesthesiologists, cardiac anesthesiologists at UPMC Presbyterian. I work with Dr. Subramaniam, that you heard a few minutes ago. I'm also leading the division of acute interventional perioperative pain service at UPMC Presbyterian here. Today we're celebrating with you, patients, and your families, and the Marfan Foundation. We're celebrating the tremendous and exciting advancements in patient care and diagnosis. And certainly pain control, pain relief is one of them. So I'm really happy to be here. I'm excited to be given the opportunity to speak to you, and I'm very humbled by this. So without further ado, we have 8 to 10 minutes to talk about this. So I just want to mention, I want to touch two quick points. Why do we need to treat pain, and how we treat pain? And this will be essentially it. It's going to fill the 10 minutes. I'm going to start off with the weird question. What is the difference between a pregnant patient who's going to deliver and a patient who's having surgery? And this is an odd question, but why do we feel the moral obligation to provide pain control to a patient who's going to deliver? And this is usually mainly through epidural analgesia, but our surgical patients are sometimes forgotten. Now, this is not happening at UPMC, as you will see, and we're very proud of that. But throughout the country, we pretty much always provide epidural analgesia for labor. But again, sometimes we fail to address post-surgical pain adequately. So why pain is bad? Well, first of all, I would argue with you that we believe that not addressing post-operative pain is kind of unethical. We put all of ourselves in providing the best care possible in diagnosis, treating. We're operating. It's an amazing act of healing. So why do we have to leave pain behind? This is not the case. This should not be the case. And then we could spend pretty much all day talking about what the effects of pain are on pretty much every system: the heart, the lungs, the guts, the brain, chronic pain. Well, uncontrolled pain or untreated pain has bad effects pretty much on every system. And we know from other surgical specialties that it increases or makes other surgical outcomes worse. And we think that this is true as well for cardiac surgery and the aortic surgery in particular. So how do we treat pain? I think we should start from the bottom: multimodal analgesia. This is a concept that expressed our ability to treat pain using multiple tools, multiple drugs, multiple techniques, with the understanding and the expectation that the combination of these techniques is more effective and better than each single technique. And then I'm going to go back to the top. So what nerve blocks are, maybe you or your loved ones, or maybe a friend of yours has received a nerve block, but the concept is really simple. Just like when you go to the dentist for a dental work, and they would numb the mouth before an operation or a procedure, we can do pretty much the same thing for pretty much every organ in our body. It's usually done prior to surgery for mostly elective procedures. If you're having emergency surgery, sometimes we do it afterwards, or we use other tools after surgery. What are these other tools? Well, medications. Pills are usually given by mouth after you're able to eat and drink as you are recovering from surgery, and IV infusion, which sometimes we use if you're not a candidate for a nerve block, and we can run infusions after surgery for several days. I'm going to spend a second talking about our pain service at UPMC, and I put a picture of me and us at Presbyterian, but I really have to recognize that this is a team effort. We have multiple teams throughout different hospitals. We are the largest in the country. We do about more than 20,000 nerve blocks per year throughout our different hospitals. And we see even more patients if you consider that sometimes, unfortunately, some patients are not good candidates for nerve blocks, and we have to do other things. We're very proud that we can provide comprehensive care to pretty much all patients. We have several speakers from the Children's Hospital, so we take care of neonates, any patient from neonates to the elderly population, all surgical procedure. Again, we're very proud of what we're doing for aortic surgery here today, but we take care of patients who are having all types of surgery: abdominal surgery, neurosurgery, thoracic surgery, orthopedic surgery, and so on and so forth. And of course, we're able to provide all the techniques that are potentially available, to all advanced techniques that are potentially available for pain management. We have a wonderful working relationship here with our surgeons, and we're very proud of that. So you don't need to ask your surgeon if you come to UPMC, but maybe if you or your loved one goes to a different place, we're technically a consult service. So just ask your surgeon to advocate for your pain, and this is the way to go. What we really believe at UPMC is that every patient has the right to get the best, most comprehensive, and most advanced care possible. And this is including pain relief and all the advanced pain relief strategies. I'm not here to promise you that you will be pain-free after surgery. Sometimes that can happen, but most of the times it won't happen for heart surgery and thoracic surgery. But we really think that every patient should get access to these techniques. And this is what we do every day. This is what we believe, and we really put our efforts into give every patient the best recovery possible. And maybe we can get to smile with you after surgery as well. I think this is it. Of course, you feel free to ask me any questions, and thank you again for your attention.
Okay, it completes our second session. I would like to open up the floor. There's a, let's see, microphone being passed around. Should there be any questions, please feel free to fire away.
My question for Dr. Singh. I have a family member who just had, he has VEDS and had the stent placed, like the endoarterial stent placed on a renal artery aneurysm. What should the follow-up, I mean, that's, as you said, like not recommended due to concerns of deteriorating the fragile artery. What's the follow-up for that? Or
So in that scenario, if a branch vessel, such as a renal artery that supplies blood to the kidney, has been therapeutically treated, the standard of care for routine follow-up would be 30 days and then 12 months. However, in this scenario, if there is a family history of a connective tissue disorder or the diagnosis of connective tissue disorder, the frequency of follow-up should be more consistent. I would propose 30 days, 6 months, 12 months, and probably every 6 months thereafter, because you're right, the concern is degeneration of the blood vessel, proximal or distal to where that stent has been placed, primarily due to the compliance mismatch. You've got a stiff metal stent inside of a fragile vessel, so I do worry about that vessel degenerating in the future.
Thank you.
Yes. We'll bring the microphone over.
So my question is about blood clots. Is there an increased risk in blood clots in any of these surgeries? Particularly, has anyone looked at patients with factor V Leiden in relation to these soft connective tissue disorders?
Well, there's a lot to be said about that. It's a topic we could spend an entire day discussing. So we'll acknowledge there are some people that are predisposed to having deep venous thrombosis, DVTs, or venous thrombotic events called pulmonary emboli. And for people that have a history of a prothrombotic state, factor V is just one of many conditions that are out there. They are at increased risk for DVT formation, both provoked and unprovoked. Most of the time, diagnosis is made before the surgical intervention. So if we do have a patient that does have factor V Leiden, is undergoing a surgical procedure, we typically will utilize ongoing anticoagulation because we recognize it's a high-risk environment. Similarly, airplane rides, car rides over 2 hours, deep sea diving, mountain climbing are all situations where those patients are at a higher risk. So they'll be anticoagulated for windows of opportunity. When they're not able to be anticoagulated, your physician may discuss an IVC filter placement, which would temporarily prevent or minimize the chance of clots breaking free from the legs and going to the lungs. Any other questions?
Yes, I had a question. Is there currently any recommended surveillance for patients who don't currently have, any symptoms of an abdominal aortic aneurysm? Do we do scans? Like, how do you?
Good news. I believe Abby Dranko is going to be talking a little bit about a lifelong surveillance and management of patients later this morning, so she'll cover that.
Oh, good.
The answer to your question is yes, yes, and yes. There are guidelines that we can follow, and she'll expand upon those ones.
Thank you.
So thank you for asking.
I have a question.
Sure.
Hope I articulate this correctly. I have VEDS, but I've also had, since the age of 17, I've been on high blood pressure medicine. And I now have what is described as resistant high blood pressure. The question that I have, 3 of my aneurysms, 2 are on top of each other in one kidney, and I have a 3rd aneurysm on the other side of the kidney. Then I have 1 in each iliac artery, both dissected there. One's a pseudoaneurysm, and then the one in my neck has dissected. It dilates a good bit, and so does the one in my iliac artery. But the question going back to, and that's just kind of giving you a full-blown thing, is the question that I have that I'm afraid to find out, but I want to know, is it possible that these aneurysms in my kidney make it so difficult to treat my blood pressure?
That is definitely a possibility. I'm going to defer to my colleague, Dr. Hoskopal, who is one of our most talented cardiologists at UPMC. And that's a great question that I would love for you to answer, because primarily what we'll talk about when people present with high blood pressure is primary essential hypertension. The question that you present, is there a secondary cause for your hypertension, and should that be managed differently? So I'll defer to him.
So the question was if there's a renal artery
So
involvement.
she has some renal artery angel degeneration, and in turn the question is, could this be the source of my poorly controlled hypertension?
It certainly could be. And would we treat it any differently? Perhaps not. We would still treat it aggressively to manage the blood pressure. But the simple answer to that question is yes, it can certainly be secondary hypertension.
Who was just talking to me?
Dr. Hoskopal, who's in the back corner. So he agrees, he thinks it is a possibility, but he would manage it with aggressive medical therapy without surgical intervention.
Such as the many medications I'm taking, is that what you're saying?
Correct. Well, if there are no, I'm sorry, one more question, please.
So she has a rupture on her, somewhere in her body, and I take her to the emergency room, bring her up here to Pittsburgh. And she's, knowing she has beds, is there a procedure you can do that actually will save her life? Or is this like a guessing game? What are we going to do when she gets here?
That's actually not an uncommon scenario. We routinely will see patients life-flighted brought into Presbyterian Shadyside Hospital in an extreme condition because of a rupture. And there's a very, very standardized protocol that we have. We have a dissection protocol and we have a rupture protocol, both of which are actually enacted long before you ever arrive at UPMC. In those situations, we're working directly with the emergency room physicians at the referring hospital. We're getting blood lined up, IV lines placed, and the air ambulance established so they can fly you directly to our hospital immediately. If imaging has been obtained at the outside hospital, we actually can view that in real time due to the fact that we have ability to share information, not just paper, not just electronic medical records, but imaging long before you arrive. And that in turn gives your surgeons, which is a comprehensive team of cardiothoracic surgeons, vascular surgeons, and we have the anesthesiologists involved as well. So everybody's on the same page, reviewing your imaging, planning, and for that air ambulance ride, whether it's 15 minutes or 60 minutes, we've got the entire team enacted, and they're ready to go as soon as you hit our door. No longer do we have to delay patient care. Now, if this is a situation that you arrive to the emergency room without imaging, yes, there might be a little bit of a lag, but we have the process set up so you go right from the ambulance, ER, CAT scanner, and right to the operating room expeditiously to minimize the chance of any delay.
What emergency room here at Pittsburgh is best suggested for that?
Come right to Presbyterian Hospital, absolutely.
Thank you.
All right, thanks.
So real quickly, the other thing I would add to that, just like Dr. Singh mentioned, is for aortic dissections, aortic ruptures, those patients oftentimes, as Dr. Singh mentioned, just come directly to the operating room from the other hospital. You put in a helicopter, you go to the helipad, you go directly from the helipad to the operating room where we're all waiting for you, or waiting for the patient and ready to go. So the idea is, as Dr. Singh was saying, no delays, no waiting in the operating room, no waiting to go to the ICU before you go to the operating room. Once we know, and as he mentioned, we can oftentimes see the imaging, but once we know that it's something that's going to the operating room, there's no stops anywhere between the helicopter pad and the operating room.
You're welcome. Any other questions that we can answer? Well, if that's it, why don't we take a break? And then we reconvene in, what do you think, Ange? What time? Let's go 5 to 10 minutes. Thank you, everybody.
All right, to kick off our next session, it's really a potpourri of talks, and this includes essentially all the non-aortic issues that we think about for patients with familial aortopathies. So the first talk is by Dr. Andy Eller, who's a professor and chief of the retina service at UPMC. So thank you, Andy.
Okay. Good morning, everybody. Can you hear me? You'd like to think that the heart's really important, but we know the purpose of the heart is just to support the eye, That's what it's all about. It just provides a little nutrition, blood flow for the eye, but it's all about the eye. But, seriously, if you think about how important our vision is to our life, losing vision is really a serious, serious problem, how it affects you from reading, watching TV. We have plenty of things for people that lose vision to do. We really stimulate their other senses to keep their mind active, but we're so reliant on vision that we often just take it for granted, but it certainly is very important. We're also very thrilled that we have a brand new UPMC Vision Institute next to Mercy. It's kind of amazing to me that UPMC plunked down about $500 million for us to put together this institute, but it's a beautiful place. And hopefully you'll never need to see the inside of our operating rooms. So let's talk about Marfan. Everyone here knows all about Marfan. We know all about what it does to the vessels and the heart, but why does it affect the eye? And when it affects the eye, it affects the cornea, the lens, the iris, the sclera, and the retina. So we know that there's a genetic defect in the stretchy fibers of our collagen, right? And that means that not just the vessels in the heart and the aortic and so on can stretch, but we also worry about the same tissues in the eye as stretching. So probably the most common problem that we see in the eye with Marfan is ectopia lentis, and I'll explain what that is, but it's seen in 60 to 87% of people, and most of the time that can be corrected with glasses, contact lenses, and rarely surgery. Strabismus, which is when an eye turns in or out, or a lazy eye amblyopia, has also been seen. And I don't treat that at all, but that's something that our pediatric ophthalmologists deal with, and is something that should be picked up early in life because it's treatable early, and once it occurs later in life, it's much harder to deal with. Myopia means nearsightedness, and lattice degeneration is a condition we see in about 30% of people overall, not just Marfan, but it is a weakness or a thinning of the retina, and it predisposes people to retinal detachment. So although it's seen in 30% of people, certainly 30% of people are not getting retinal detachments. It's still pretty rare, but we know that it is a risk factor. It's something we look for and document when we do eye exams. But we also know that people with Marfan have a higher risk of retinal detachment. You can see the survey 5 to 26%. I was thinking as I was looking at my slides of my 40 years in practice, I've not done that many surgeries on people with Marfan, they're very memorable, because the eye's so different that it's a little trickier to work on, but I think I've been successful in the ones that I've operated on. And it occurs in both eyes in 30 to 42% of people, so that's much higher than the general population. If someone has a retinal detachment in one eye, typically it's 10 to 20% risk of the fellow eye. The pupils tend to be a little bit smaller, and we can get acute glaucoma from the lens, and I'll talk about that in a minute. So here's the cornea. This is a cornea on profile. The cornea is our windshield of the eye, or I like to say the watch crystal of our eye. It's the dome. And when the fibers in the cornea are more stretchy, the cornea is going to be thinner and it's going to be flatter. So just doing cornea surgery is a little trickier. It's hard to put sutures through the cornea as it is when you have to sew it, let alone sew a cornea when it's super thin. Sometimes we can even glue the cornea. When I should go back, well, I'll go forward. The ectopia, which means topia is the topography, how things are laid out. Ectopia means it's out of center, out of line. And we worry about the zonules. The lens of the eye is held in place by little strings or fibers called zonules. It's kind of like the springs on a trampoline. And those springs have to be even all the way around. But if on one side of the trampoline, the springs are a little looser, the mat is going to be pulled over to the side. That's ectopia lentis. And here you can see the one slide shows these fibers, the zonules, that hold the lens in place. And the lens is like an M&M. When we're born, it's clear. It has a thin candy shell, has chocolate inside, As we age, that chocolate gets harder, it becomes like a peanut M&M. That's what a cataract is, okay? So you got the thin candy shell, you got the peanut M&M, and you got these little springs, like on a trampoline, or the fibers holding everything in place. And this is what happens in Marfan's as the fibers get stretched out. And when they get stretched out on one side, the lens moves upward, typically, in Marfan, and that's why we call it, it's out of position. It's an ectopia lentis. Now, typically, this can be fixed with, or corrected for, I should say, with glasses or contact lenses. You don't absolutely need surgery, but you may have some astigmatism induced by it or irregularity in the glasses, so it could be a little trickier, but you don't have to absolutely get glasses for it. When you develop a cataract, which is when that chocolate becomes a peanut M&M and it gets harder, then you can't see through the lens and you have to do surgery. That's when it gets trickier. And cataract surgeons have special gadgets that they can use that can support the thin candy shell, because when we do cataract surgery, we actually want to use that thin candy shell of the M&M to support the implant lens. In the old days when we did cataract surgery, we took out the entire lens, and then people needed thick glasses, like Mr. Magoo, or a thick contact lens. But when you do cataract surgery with the capsule in place, with the thin candy shell, we fold up an implant lens, so it's like a soft contact lens, and we stick it into the thin candy shell and it unfolds, and that's how we correct for cataract surgery. Well, that's hard to do if the thin candy shell is being pulled off to the side, so we have little tricks we can do to fix that. If the lens comes forward, if the zonules break completely, the lens comes forward, and now it's hitting the front of the eye, that can cause acute glaucoma. We have different types of glaucoma. We have chronic, where people need eye drops and so on. But acute glaucoma, there's a blockage of the outflow. The eye makes fluid. If we have blood flow that nourishes our organs, but if you had blood flowing into the eye, you wouldn't see. So the body, or the eye, has this really cool gadget that blood flows through it. The blood's filtered away, and the clear liquid in our body, in our bloodstream, with all the proteins and nutrients, is pumped into the eye, and that nourishes the inside of the eye. And then it drains out of the eye, so there's a constant flow. Well, when the lens comes to the front of the eye, it plugs the drain, and then that causes acute glaucoma. Acute glaucoma is a sudden, painful loss of vision kind of problem, and you won't miss it. You're gonna come right to the ER and say, my eye is killing me. Now, this is a picture of the back of the eye, and you can see that the lens has actually fallen all the way in the back. And I actually have one patient who has this, and I've just put him on contact lenses. We've not done surgery to remove it, although we could. I just watch him once a year to make sure he's stable, and he does really well without needing the surgery, and I would really rather avoid operating on him. So what are the visual symptoms of ectopia lentis? Blurred vision, double vision, astigmatism, and the lens can come forward or backward. Now let's talk about the back of the eye. This is the most important thing as a retina specialist. I always say that when Rocky or Arnold Schwarzenegger go to the gym and they pump weights, they get bigger and bigger and stronger, but when the eye gets bigger and stretched out, the tissues get thinner. It's more like a balloon. The more air you put in the balloon, the stretchier it gets, the thinner the wall is, and because the retina then is on stretch, it's going to be at a higher risk for retinal detachment. Now, you don't have to have Marfan to have a high myopia, but certainly it's more common with Marfan. So what happens with the retinal detachment? The inside of the eye is full of a jelly. It's like egg white of the eye. It fills the inside of the eye. It's called vitreous. And the vitreous, as we age, gets more watery. When it gets more watery, it collapses, it pulls away from the retina. And if you put Scotch tape on your wallpaper and you pulled it away, you'd get paint flecks. Those paint flecks float inside the eye. Light comes in the eye, hits the floaters, and when you look at a white wall, you see these cobwebby things. If that happens acutely, suddenly you need to see an ophthalmologist within a day. When the jelly pulls on the retina, it doesn't hurt. There's no pain, there's no headache, but it will flash lights. And those flashing lights tend to be like little lightning streaks across the top, and they tend to be so dim people see them in the evening. And that's a sign that the retina is in distress. You see flashing lights like this and floaters, you need to see an ophthalmologist right away. And someone said, if I have a heart problem, where do I go? And they said, go to the ER Presby. We just moved all of our ophthalmology stuff from Presby to Mercy because that's where our new Vision Institute is. So you would come to Mercy. And ideally, we would, if the retina tears from the jelly pulling, we would catch you early and we could laser it. But once the tear develops into a detachment, then we can't do that. And you can see here where the tear is. If the retina is still attached with a tear, then we can laser it and seal it and prevent surgery. But if you wait, the jelly, which is becoming liquid, the water goes through the tear and the retina peels away, just the way wallpaper peels away. Remember, wallpaper, when you take it off, it's seamless, so that if you want to steam it off, you get the steam behind the seam and it peels away. The retina is seamless, but if you have a tear in it, now the fluid can go through it. And so this is what a retinal detachment looks like, and we have lots of tricks to fix those, and they should be. So when do you see an ophthalmologist? If you have family history of Marfan, if you have a diagnosis of the aorta, you should really come over and let us take a look and see what's going on. And obviously, if you have new ocular symptoms, blurred vision, double vision, loss of vision, flashing lights, floaters, you need to be seen right away. Thank you.
Thank you, Andy. My wife's an ophthalmologist, and I can attest to the first statement he made, which is the function of the heart just to pump blood to the eyeball.
You hear that every day, don't you?
Oh, yeah, without fail. Next is Alyssa Castor. She's our outpatient chief, APP. She spent quite a bit of time really seeing patients, partnering with patients who have aortic disease, and somebody who we work with every day, and most importantly, somebody who tells me what to do every day. So, thanks, Alyssa.
Thank you. All right, my name is Alyssa Castor. I'm a physician assistant here at UPMC with cardiac surgery and the UPMC Center for Aortic Disease. And it's my pleasure today to talk about quality of life as it pertains to physical activity and exercise in patients with connective tissue disease. So to understand why there are physical modifications required for patients with connective tissue disease, let's first go back to the pathophysiology of connective tissue disorders, which several of our colleagues have already discussed today. But connective tissue is a general term for the group of tissues in the bodies that provide support and structure and form. They suspend organs, and examples include bones, ligaments, tendons, cartilage, and fat. In connective tissue diseases, gene mutations result in weakened extracellular matrix, which is the foundation for the formation of these tissues, rendering connective tissues weaker than normal. So as providers, what are our concerns with high impact, high intensity physical activity for patients with weakened connective tissues? First, Dr. Eller, I did say ocular first, wherever he is. We are worried about the eyes, particularly in high impact sports, because of the abnormal globe shape and the laxity to the support structures for the eye. These patients are at higher risk for lens dislocation and retinal tears and detachment. Next, for patients with Marfan syndrome, there are higher rates of fractures. This is related to the osteopenia or weakened bone, as well as joint dislocations because of the laxity of the joint structure. Lastly, and particularly for us in the cardiac surgery world, we worry about aortic injury. It's been discussed already and will be mentioned again that the inner layer of the aortic wall, the intima, is comprised of connective tissue as well and is weakened. And with high blood pressures, we worry about tears or disruption of the internal wall, leading to aortic dissection, which can be a dangerous and life-threatening emergency. So there's three key messages I wanted to make sure that you took away from today. The first is the importance of establishing with a center of excellence and identifying providers you can trust. This has been mentioned multiple times today already, but the 2022 ACC/AHA guidelines do emphasize the importance of establishing with a center of excellence. This allows you to have multidisciplinary care, access to a large network of subspecialists, and develop a patient-provider relationship over time. And in regard to physical activity, this patient-provider relationship is very important. It's important to have providers that you can trust, because while I'm going to go over the basic do's and don'ts for patients with connective tissue disorder, ultimately the specifics of your physical activity really need to be discussed with your provider, and you should have somebody that you feel comfortable asking vulnerable questions to. Second, please stay active. We know that physical activity is vital for both a mental and emotional health. It's also beneficial for long-term management of high blood pressure. And lastly, don't focus on your limitations. In general, most people living with connective tissue disorders can and should exercise regularly through low-intensity, low-impact aerobic exercise. And most activities can be adapted in a way that patients with Marfan syndrome can still enjoy those things. All right, so what are my restrictions? First off, we recommend staying away from high contact competitive sports. So these are things like rugby, football, and competitive basketball, and that's because of the risk of blow or facial trauma. High impact sports that are hard on the joints. Exercises that cause an increase in blood pressure, particularly isometric exercises and heavy lifting. So first off, isometric exercises are any activities in which a muscle is contracting without changing in length and without joints around that muscle moving. These are typically done over a period of time for core strength, and examples are planking, squatting, dead hangs, and wall Pilates. Heavy lifting. This is a term that we are very quick to throw around as providers, but don't always give a lot of specifics to, and it can feel very vague to you as the patient. So in a well-cited, well-respected paper in the American Heart Association Journal regarding activity recommendations for post-aortic dissection patients, it is suggested that we should define heavy lifting as anything that causes a patient to Valsalva. Valsalva is a maneuver when you bear down, so if you were straining to have a difficult bowel movement, that's the maneuver, the Valsalva maneuver. So when thinking about what is heavy lifting, it's anything that would cause you to strain, grunt, or jolt your body to lift that object. Interestingly, this same paper also found that we should avoid pushing to the point of exhaustion. They define that the point of exhaustion is the last repetition able to be performed before reaching fatigue. So that very last bicep curl that could be performed with no others after that, that's the point of exhaustion. That is when peak systolic blood pressure increases occur. And interestingly, they found it was regardless of the degree of weight that was being lifted. So whether it's low weight at high repetition or high weight at low repetition, if you reach the point of exhaustion, you're reaching dangerous levels of blood pressure increase. All right, so what physical activity is safe? Regular, mild to moderate, preferably aerobic exercise is both safe and highly encouraged for most patients with connective tissue disease. And you should aim between 3 and 5 metabolic equivalents. So what is a metabolic equivalent? This is a unit of measurement that estimates the amount of oxygen consumption or energy required to complete an activity. So 1 MET is equivalent to what we're doing here, just sitting at rest. As the intensity of activity increases, the MET value goes up. And I know it's kind of small on the screen, but to the right you can see the table that has different activities listed and their corresponding MET values. And again, we recommend between 3 and 5 METs with the suggestion that an MET, with each MET, the top number of the blood pressure increases by 8 to 12 points. So while heavy lifting and competitive weightlifting is discouraged, weightlifting can be done with lower weight and higher repetitions as long as you're remembering to stop before the point of exhaustion, which we just discussed, never strain, and always use proper form. All right, lastly, we can't fully address the topic of physical restrictions for patients with connective tissue disease without talking about sex. So in regard to sex, a couple important points. First, sex is safe, apologies, for patients with connective tissue disease. Sex is also safe for post-aortic dissection patients, and it's typically after 4 to 6 weeks after the acute event, whether that's surgery or medical management, and it's important that you're cleared by your provider. The AHA paper that I referenced earlier reported only, quote, moderate effects on blood pressure and heart rate among healthy individuals during sexual intercourse, with a peak increase in systolic blood pressure of 40 points. This paper describes in general that sex is safe for the post-dissection patient and encourages just an overall common sense approach to sexual activity. Lastly, use of erectile dysfunction medications should 100% be discussed with your provider, and this echoes back to the important point of having a provider you can trust, that you feel comfortable with, and you can ask those vulnerable questions too. It varies from patient to patient depending on your disease process, but it's an important part of quality of life, and you should not be afraid to ask about it. So I hope today that you hear from this platform and all the providers how much we appreciate you being here, and we acknowledge the unique challenges that you each face. And while we have the honor of partnering with you in managing your disease, we recognize that we don't walk the same path that you do each day. So we thank you for your trust, and we acknowledge you for your courage, and I just hope that you leave here today feeling a bit more equipped and empowered and connected. So thank you, guys.
Our next speaker is Dr. Agnes Kocho, who's a clinical instructor in medicine and is one of the key leaders in the Women's Health Heart Program. You know, one of the nice things about this session is to look at everything else that's non-aortic and aortic patients. For instance, if you happen to have VADS and you have bowel obstruction, you know, or other concomitant diseases and conditions, we want to make sure that you have pathways to get to a facility where you have experts, and this talk happens to be similar. Thank you, Agnes.
Thank you so much, Dr. Sultan, for the invitation, and thank you so much to the Marfan Foundation for putting together this wonderful symposium today. As Dr. Sultan mentioned, I'm one of the adult cardiologists, but my primary clinical work is at the freestanding obstetric hospital, the McGee Women's Hospital, and I'm truly passionate and do a lot of clinical work in cardiac problems in pregnancy, including in patients with Marfan syndrome. So I think important to acknowledge that, of course, pursuing parenthood or family expansion can go beyond pregnancy, right? There's many wonderful ways to expand your family with adoption, surrogacy, et cetera. But in this short talk today, we'll sort of focus on pregnancy. I think when patients come to me, these are some of the things in the outline I wanted to address today. So things to consider prior to pregnancy, care during pregnancy, a couple of nuances about delivery, and then where to go for your care. So let's start with things to consider prior to pregnancy. So if you are considering pregnancy and thinking about going to see your cardiologist specialist, you're already ahead of the curve. So as you'll see from some of our data presented today, preparation is really key. Among the patients that we see that unfortunately have bad things happen to them during pregnancy, most times it's because they haven't received their diagnosis yet of Marfan syndrome or a connective tissue disorder, and they haven't had a cardiologist or a specialist sort of closely following them. Certainly the biggest concern that we have in patients pursuing pregnancy and during the time of delivery is really what's going on to the aorta, as you've heard today. Of course, it's a really important, can be a really dangerous sort of manifestation of these connective tissue disorders. Of course, among these, aortic dissection is the most serious pregnancy concern that we consider very closely and like to talk to our patients about. In looking at reports of patients that have unfortunately had aortic dissections during pregnancy, or as we'll learn after pregnancy, they're still at risk. Unfortunately, Marfan syndrome is found to be the most frequent cause. So we're very thoughtful and about talking to patients with Marfan syndrome, but really all the connective tissue disorders about risk for aortic dissection. So when my patients come to see me, these are some of the questions you might have or that have come up in our sort of preconception phase. So how often do complications like aortic dissection occur? What would put me at risk, maybe at higher risk than somebody else that has Marfan syndrome, Loewy-Dietz, Ehlers-Danlos, et cetera? Will pregnancy or having children have long-term impacts on my heart and the arteries? And do I need any procedures or surgery, like we had some wonderful discussions about? Does that need to occur before I pursue pregnancy to make sure I have a really safe pregnancy and delivery? So there's a lot of really wonderful groups that have looked at trying to characterize, what is really the risk of aortic dissection. This was one of the recent kind of largest studies that came out of it. This was all patients with Marfan syndrome. It looked at patients across about 10 years that had 152 total pregnancies, and of those, 112 resulted in live births. Among that subset of patients, 5 patients unfortunately experienced aortic dissection, which puts the percentage risk around 4.4%, which seems low, but of course these are really serious implications, right? So when we looked at, who ended up with these unfortunate complications, 2 people with Marfan syndrome suffered a type A dissection, which of course is in that more proximal part of the artery, which I think we discussed extensively before, can be sort of more catastrophic or even more dangerous than these type B dissections. It occurred in late 3rd trimester and in late pregnancy. And looking back at what the sizes were when this occurred, they were quite large in these patients. Their aortic roots were about 5.6 centimeters. In another 2 patients, they noted type B dissection. Among these patients, they had actually gone through pregnancy, had delivered, and it was actually in this early postpartum period. And we'll talk about we're really careful with screening even after delivery because unfortunately things can happen then too. Notably, when we looked at their sort of aorta dimensions, how big or small they were, they actually were noted to have pretty small aortic roots. And as we'll talk about, type B dissection can be sort of less predictable than type A dissection. And then 1 person suffered a coronary dissection, which is the arteries that feed blood and nutrients to the heart, also with a normal aortic root, and also had gone through a pretty uneventful pregnancy and delivery, and then had this unfortunate complication in early postpartum. I think the most important thing to be aware of from this paper were that 4 out of 5 patients that had complications actually had not been diagnosed with Marfan syndrome. So of course, really important to educate both patients and providers, right, to recognize this, get genetic testing, get family screening, so that when people go to pursue pregnancies, that they're able to do it in a safe way. So some of the lessons learned from this paper and other papers like this, the rate of aortic dissection during or really after pregnancy is thought to occur in about 4% of patients. Again, sort of a low percentage, but is not 0, and we wish it to be 0, right? So certainly something we talk a lot about with our patients about. Most often this will occur in later pregnancy, but can occur out to 3 months postpartum. So again, we're gonna follow you very closely in the sort of postpartum setting to make sure the aorta isn't expanding or there aren't any sort of concerning findings. Type A aortic dissection, most of the patients in prior studies were unaware that they had Marfan syndrome or a connective tissue disorder, and so their aortas weren't really being followed. And this is probably sort of one of the risk factors that led to these complications. Unfortunately, though, type B dissections or dissections that occur in the sort of lower part of the aorta were less predictable, and we're not as able to counsel on whether or not that's going to occur. What they noticed when they followed the size of the aortas throughout pregnancy is that people who had smaller aortas did not tend to grow throughout pregnancy. We do know between all of the hormonal changes in pregnancy and all of the fluid volume shifts that it's certainly a possibility, and they did observe some changes in patients that had bigger aortas that they actually did expand during pregnancy, and it's something we talk to patients about. And then again, addressing the question of if I have children, is this going to impact my lifetime risk of dissection? In this paper, no. So, ever pregnant versus non-pregnant patients did not have an increased risk of dissection throughout their lifetimes. However, this is kind of an evolving area. Some patients ask me, and it's important to address, should I have surgery before pregnancy? So we know, and there's guidance now, that if your aortic root diameter is getting bigger, as we saw with studies, that's really kind of one of the predictors for bad outcomes. So we will often send you and talk with our cardiac surgeons about potentially getting that repaired before pregnancy to ensure sort of the safest pregnancy and delivery for you. I think there's also sort of intermediate ranges of aortic root diameters between 4 and 4.5, where we'll ask you more questions about, do you have a family history of dissection, which may play into it, and has your aortic root been growing particularly quickly over time? How about care during pregnancy? So from a medical perspective, we're really careful to treat high blood pressure, and typically in pregnancy, actually blood pressure decreases. There are, of course, hypertensive disorders of pregnancy, which tend to actually be more prevalent in patients with different types of congenital heart syndromes. We really focus on using beta blockers during pregnancy. We have some pretty good data, particularly with certain medication or certain types of beta blockers like metoprolol, that they're really safe in pregnancy. If you are on one of those TAN medications like Dr. Wolf pointed out, valsartan, losartan, there's some data that may provide injury to the fetal kidneys, so we will take you off of that medication for the duration of your pregnancy. Again, we're really careful to monitor you with heart echoes to monitor that aortic root size, make sure it's not growing too much or too fast. At least every trimester, we usually do a heart echo of the aortic size. And again, really important during this postpartum setting to closely monitor that aorta. Mostly for patients that have not had their full aorta imaged. If they happen to experience pregnancy and they do, have suspected or confirmed connective tissue disease like Marfan's, we can do an MRI of the aorta. Luckily, MRIs do not use radiation or contrast, so we can do these pretty safely and still get an idea of your aortic dimensions throughout pregnancy. How about delivery? So in general, we tend to favor vaginal delivery, but C-section delivery, of course, is also a great option. Just as Elisa had spoken about, Valsalva is something that we want to avoid, particularly if your aorta is big. So oftentimes we will only really allow you to do a lot of this valsalving, which of course you do a lot of in sort of actively pushing the baby out with aortic sizes under 4 centimeters, even with patients say with Marfan syndrome that aortic size is under 4 centimeters, we will try to shorten the amount of time you spend in that active stage of pushing. And then we also coordinate with our obstetric colleagues to utilize some obstetric techniques to help the baby come out quickly. C-section delivery is, of course, an option which wouldn't involve you valsalving down and in general is not associated with as many blood pressure and heart rate fluctuations as vaginal delivery. And we tend to recommend C-section deliveries if your aorta is over 4 centimeters or if you have a history of chronic dissection. And last is sort of where to go. So at McGee, we have, as you guys have met, several very active adult congenital heart disease doctors and adult cardiologists who are passionate about cardiac care in pregnancy. Up top are just Dr. Hoskopal, Dr. Serif, and Dr. Wolf. You heard some of them talk today, who are not only trained in adult congenital heart disease, but are very passionate about taking care of patients through pregnancy. And our cardiobstetric or adult cardiology care in pregnancy group is down here, myself, Dr. Berlacher, and Dr. Contreras. So happy to talk to you if you're thinking about pregnancy, thinking about expanding your family, and then happy to take care of you through pregnancy and delivery. Thank you.
Thank you. One of the things we worry about, or one of the first times patients get diagnosed or told about any connective tissue disorder is when it's an emergency, when you suffer an aortic dissection. And, how do you navigate that? What happens when you show up to the emergency room with chest pain? So Abby will talk to you about this. Abby's an expert APP with cardiac surgery and the aortic center, who's worked with patients with connective tissue disorders for a long time. She's also a meme aficionado, in case anyone's wondering.
Okay, hi, my name's Abby Graham-Pardis. I'm one of the physician assistants here with cardiac surgery at the Aortic Center. I take care of the patients both before and after cardiac surgery, as well as for surveillance. And today I'm going to talk to you about aortic emergencies. All right. All right, I'm the worst. I don't know how to make this go forward. I did click. Oh, there we go. All right, I have no disclosures. Okay, so what is an acute aortic emergency? Briefly, the aorta is the largest artery in the body. The oxygenated blood leaves your heart through the aortic valve into the aorta to be distributed to the rest of your body. You guys have seen this a bunch of times today. So it goes to the brain, the arms, the GI system, the kidneys, etc. The aortic wall has 3 layers. An acute aortic syndrome is where there's a breach in these walls. The most common acute aortic syndrome is an aortic dissection, as well as intramural hematomas, penetrating atherosclerotic ulcers. There are different classifications to describe the location and extent of the damage to these walls, but these are all acute medical emergencies. So why does this matter to you? Connective tissue is an important component of blood vessel walls. Some connective tissue disorders affect blood vessel wall integrity, increasing the risk for acute aortic syndromes, most notably Marfan, Loeys-Dietz, and vascular EDS. So when talking about acute aortic emergencies, the most important thing to remember is that time matters. Preparing for an emergency is really preventing a delay in care, because with delays in care, bad things can happen to your organs when they don't get enough blood, and unfortunately, sometimes people die, which is really uncomfortable to talk about, but part of why you're here, and we want to help prevent that. So how do you prepare for this? First, it's important to know the symptoms. So there's classic description of severe tearing chest pain, but you have to remember that because the aorta feeds the rest of the body with blood, you can have symptoms from lack of blood flow anywhere. This is unfortunately how dissections can sometimes be missed. There can be shortness of breath from the valve being disrupted. There can be stroke-like symptoms from lack of blood flow to the legs. Sometimes people pass out, and sometimes people just don't feel right. If you have symptoms, call 911 and go to the closest ER. Early diagnosis is key, and then management and transfer can be addressed if you're not in the right place. And nowadays, we have helicopters. Next, it's important to establish care with a multidisciplinary aortic center, which has also been touched on many times. You'll have established emergency medical contact if symptoms do develop, and we'll talk about that a little bit more later. You'll undergo serial imaging interpreted by experts to monitor accurate aortic size and determine if there's been growth of your aorta. You'll be able to have prophylactic or preventative surgery when it's indicated based on the latest guidelines and standards of care, and you'll have an established relationship with a surgeon. So if you do need emergency surgery, it will already be somebody you know. You'll have a documented medical history on file, so we'll know going into surgery what other medical issues you might have or whether or not you're on blood thinners. You should carry a wallet-sized card with you, both for your local team and if you have a specific condition. So this is the card we have at UPMC, and there's some back there if you want to take one with you. It has information for patients on one side with symptoms and for medical providers on the other side. So when you take it to the ER, it lets them know how to get in touch with our surgeons, expedite how to get imaging to them for review, and then allow them to get in touch for transfer if necessary. There's also cards on different websites. So the Marfan Foundation has a downloadable card, and so does the Loeys-Dietz website and the Vascular EDS website. So you can print these out and put them in your wallet. If emergency symptoms do develop, you will need to be your own advocate sometimes. First, call 911. You'll be seen faster than if you go to the ER and sit in the waiting room. Call your aortic center team. They'll be able to help facilitate ER evaluation, either at the ER such as here at Presby or a local ER, and they can get you to a higher level of care. When you get to the ER, let the ER staff know that you have Marfan syndrome or another connective tissue disorder. Let them know that you think you're having an aortic dissection or emergency and that you require emergent imaging. Give the ER staff your physician contact information or the wallet card. An X-ray will not diagnose an aortic dissection. An aortic dissection can only be diagnosed with a CT scan with contrast or dye, an MRI, or an echocardiogram, which is an ultrasound of the heart. To fully evaluate your entire aorta, you need a CT scan or an MRI. If you think that you're having an aortic dissection and an X-ray is done in the ER and they try to send you home, that's not okay. It's okay to be a difficult patient sometimes. That's when it's good to have an aortic center team available to you. You can call them and they can help work with an ER. It's also helpful to inform your community. Make sure your family knows. Tell your coworkers that you're comfortable with. As many people as you know that you can let know what symptoms to look for, call 911, tell emergency providers what is going on and what to look for, the better. Local EMS want to know about patients with high-risk conditions in their area so that they know how to better manage them. Call them and let them know that you have Marfan syndrome or another condition and are at risk for an aortic dissection. Consider medical alert bracelets. They also have seatbelt wraps like you see here if something happens. You should also know how to have your phone call 911 easily. It's different for every phone, but you can talk to them and tell them what to do. Teach your kids. So to summarize, know the symptoms, establish with a multidisciplinary center, carry a wallet card, advocate for yourself, and inform your community. These are the references. It's the paper everybody's talking about, the different websites. And then if you want to be seen at the Cardiac Surgery Center, we are happy to see you. We do telemedicine visits if you want to establish for imaging surveillance, and with my contact information. So thank you very much.
All right, we'll keep going. So this is one of the most special parts of the day. As I said, one of our favorite patients, Steph, will share her life journey, little tips and tricks, things that she can share with us, providers, patients, families, and support folks. Alyssa's going to sit with her, and we'll try to make this as interactive as possible. So thank you, Steph.
Please do. Hello, everybody. Thanks for being here with us today. My name is Stephanie. I am 45 years old and got my confirmation of Marfan syndrome 2 years ago, roughly. However, because of my age, we clearly didn't have all the advancements that they talked about today. I had a lot of the telltale signs of Marfan syndrome. However, I also had a lot of things that were not textbook definition. And I think, the one thing that I have learned is that it really does present itself differently in every single person. There's certainly traits that I'm catching on to now, but while I may have been flat-footed and loose ligaments and super flexible, I was an overweight child, so I didn't fit that super tall, slender shape that typically comes along with Marfan's. The more I learned about it, the more it started to make sense. Again, I said the flat feet, I have the narrow top palate with crowded teeth. I have had several knee surgeries for loose ligaments and things like that. I have scoliosis, which was diagnosed in 5th grade, I want to say, roughly 5th grade. I was probably about 13 years old, and they found it in gym class. So my hope and goal is that we can start to educate those people, the school nurses, the gym teachers, and the people who are actually with the kids, who now have the insights to when when you're being tested for scoliosis or treated for flat feet, that this is a natural progression of finding that. And that's really what I hope to see. Because I still walk into places, medical places that are not UPMC, and they've never heard of it. Or they look at me like, you have what? And I really look forward to that not happening anymore. And I'm willing to tell my story from the rooftops so that the next set of children who have this can be ahead of the curve. What's really ironic that this symposium today is that as I shared, I had my aortic dissection Mom probably shared it earlier, when I was 37 years old, which was the same age as my grandfather, who we believe is the one who had Marfan originally. We're in the process of testing the rest of my immediate family right now. Luckily, none of them have endured anything that looks similar, but the opportunity to be proactive and get them scanned to avoid this excites me in ways that I can't even explain. Next Saturday, I will be coming back here. I'm going to spend another weekend with these fine folks to have a open aortic aneurysm repair, basically getting a man-made aorta next weekend, or next Monday. So timing was pretty impeccable, and it's why I'm so emotional over this. But I'm really thankful that you're all here, and to learn that, something that I spent 43 years of thinking I was dealt a crap hand or just had bad luck, and to realize that there's an entire community of people going through this is really awesome. Thank you for listening to my story.
Thank you, Steph. Next, we have Abby Dronko, who's one of our lead vascular surgery APPs at the Shadyside Hospital, working with Dr. Singh. Talk to us about navigating lifelong care challenges.
Hello, everyone. So thank you for the introduction. And obviously, my name's Abby, and I'm one of the vascular PAs working here at Shadyside. I'm honored to be here. I think this is absolutely amazing, and seeing all of you and talking with all of you is just wonderful. And so what we're going to be talking about today, very briefly, is navigating lifelong care challenges. I have no disclosures. So setting the stage for my discussion, obviously at this point we know what conditions we're referring to. And I put a definition up here of challenge, and not because I don't think all of you can define challenge. I did it because I bet if I asked a handful of you to tell me what a challenge is, your definition would vary even just a little bit. And I do that because I want to emphasize that every patient is an individual, and every patient comes with their own set of individual challenges, and we have to remember that when we're treating them. When we go through our talk today, a lot of the data that I'm pulling was specifically done on Marfan syndrome, but of course the findings can be generalized to all heritable thoracic aortic disease or aortopathies. So these lifelong care challenges obviously start before diagnosis, and as we just heard, I mean, that's the epitome of this slide. So I included some quotes that I've heard from patients, but also that I've seen in doing some research, and such as, the NICU nurses noticed that I had really long fingers. I saw a book at Starbucks about Marfan syndrome, and that was a mother specifically talking about how she was able to reach her child's diagnosis. It wasn't until I was diagnosed with my second aneurysm And I was told I didn't, quote, fit the look, even though my dad passed from a dissection. So again, just highlighting these experiences from patients, that the challenges start from the beginning. And I think we've come a long way in medicine, and in this area in particular, but I think there's still a lot to do. And this also really highlights that it's absolutely imperative that we take a proactive rather than reactive approach to managing patients. Obviously, there's detrimental cardiovascular events that can occur, and a lot of these can occur in childhood or adolescence. So it's very important that we secure the diagnosis. Care challenges tend to peak at this transition period, and what is this period? This is the crucial period when a patient is transitioning from their pediatric to adult care. And typically we think about that between the ages of 18 and 21, but ideally it should start as early as 16. And why? Why is this such a crucial period? So there's this double change of responsibility that occurs. So instead of parents and pediatric physicians being the sole, responsible party for the care, it now transitions to patients and then all of the adult physicians and specialists. I mean, we've heard from a slew of different specialists today, and that's just the tip of the iceberg that should be a part of this team caring for patients. And then patients are now, responsible for their tasks and their care organization, and so it's an overwhelming process. And again, I've seen a lot of research showing that this is when we're starting to see a lot of these complications, and serious ones: aortic root dilation, mitral valve prolapse, and then lens dislocation as well. And this is one thing that I really want to emphasize today, and we'll talk about a little bit more, but patients are lost to follow-up at this period because, again, they're adolescents going into adulthood. The last thing that they want to think about is when they need their scans and appointments, and it's a lot. But we know in this patient population that surveillance is absolutely crucial because a lot of these complications occur randomly and without, knowing when and kind of how. So these lifelong care challenges obviously don't stop at that period. They continue throughout adulthood. So whether it's imaging surveillance, surgical intervention, whether it's prophylactic or emergent, and then multidisciplinary care. Now, to briefly touch on imaging surveillance, I didn't want to put a bunch of charts and graphs and things on these slides to overwhelm anyone, but I think the general consensus is that something annually, and I say something because of course we'll talk about different types of imaging, but is kind of key. Now, most providers kind of recommend at least a one-time kind of CTA or a contrasted CT scan at diagnosis. Now, in most patients, Marfan's and EDS, you can kind of say mostly of the aorta is kind of the most important area to image. But in LDS, of course, we're wanting to look at the whole body because these pathologies can occur throughout. So most of the things I was finding, and again, it varies between organizations and providers, and again, emphasizing the point that everybody is an individual, so their particular surveillance is going to differ. Echocardiograms, of course, are a great way to image the ascending and then the abdominal aorta, but you're missing a section in the chest because you can't really see it that well there, so an MRI or a CT scan is how you would do that. But again, we want to avoid putting these patients through multiple contrasted scans every single year because contrast is not great for you either and can be taxing on the kidneys. So an MRI is another option as well. Now, patients that have undergone surgical repair, 6 months to a year is kind of the general consensus, but of course it can vary and it's going to be individualized based on what the patient has or has had done. And so kind of circling back to this multidisciplinary care approach, and I know you've heard this word about 1,000 times today, so, and of course we know what it is. It's a group of individuals with different expertise that are working together towards a common goal. And again, whether that's prophylactic medication, surgical intervention, or just education, support, and resources. And of course, we're referring to these kind of aortic centers or Marfan centers, where you have experts that gather cases, we discuss the cases, we discuss each patient, and again, it's never enough to have one provider looking at your case. I thought this was an interesting survey, so I threw it in here. This was actually done in Germany, but they surveyed about 77 patients with Marfan syndrome, and they asked them, what is the most important aspect to you in a Marfan center? So 33% said competence of their medical team, 29% said multidisciplinary care, and then 15% said their trust in their provider, overcoming fear, and then explanations as well. So who should be involved? Obviously, this is not an exhaustive list. We have a lot of surgeons on here and ones that we've heard from today. And at the very end, of course, I've highlighted the patient. We can't lose sight of the patient in this whole process. Obviously, we as providers are talking to each other all the time, gathering opinions, expertise, but we can't forget that the patient is a part of this, and our recommendations have to align with their goals and their specific situation. One area that I kind of wanted to focus on a little bit more is psychological support. So we've spent a lot of time today talking about surgery, of course. But psychological support cannot be ignored in these patients, and really it should begin as early as their diagnosis. We know that patients with connective tissue disorders have higher levels of depression, anxiety, and reduced quality of life. I even read in one study as high as 94% of participants said that they have a high level of psychological distress. So that's important. It absolutely has to be a part of the multidisciplinary care team. And some specific considerations that I myself necessarily didn't think about initially. Traumatic experiences, whether it's just the diagnosis or it's having or experiencing an actual aortic complication. That's very traumatic, and we have to remember that. And then, of course, in the pediatric and adolescent population, body image, and then risk behavior, which kind of goes along with that. So you're expecting children to not only live with a very difficult diagnosis and the potential complications, but also talking about major surgeries and, you know, these catastrophic events that can happen, and all they want to do is be kids, and they want to be, you know, they want to assimilate with their peers. So when they feel like they can't do that, then sometimes they partake in some risk behaviors, and not even just drugs and alcohol and all the things that you initially think of, but they also don't want to follow up. They don't want to take their medications. They don't want to do all those things. So we have to remember that that is a huge part of this, and that's why psychological support is so important. I threw this in here quickly, and we did briefly touch on it as well already, but some factors that are associated with higher versus lower levels of quality of life. And one that I particularly highlighted was participation in work, because it's just human nature. We associate work, you know, not always in the positive light. I mean, all of us here do, of course. But, you know, it's found that patients with these disorders actually participating in work and having sort of a purpose is associated with a higher quality of life. So it's improved social situations, finances, self-esteem, and a sense of independence. So something that we might overlook is very important to focus on with these patients. Education is empowerment, and so I feel very strongly about this because, and this does not only just mean education on the patient side, but also the provider side. And we've touched on these topics today, but, you know, not just educating on the diagnosis and the disease and surgery, but also all the other nuances of life, exercise, career choice, and then of course, activities. You don't think of scuba diving or traveling and flying in unpressurized aircrafts as something that you talk to your patients about every day, but it has to be with these patients. And then provider awareness. So increased awareness amongst providers leads to improved life expectancy. I included another survey that I thought was also very interesting. This was actually done out of Kentucky, I believe, only last year, so not that long ago. And they interviewed pediatric residents, attendings, APPs, and some other specialists, and kind of was trying to gather their comfort level or their familiarity with specifically EDS. So we start off strong. 94% have heard of EDS. 79% have learned about it, but then we jump down to 9% that are only, you know, completely or very comfortable with diagnostic criteria, 4% diagnosing, and 7% educating. And all of them kind of reported that the reason for this was that there's a lack of educational materials, knowledge, and competence. Now again, I think we're making great strides with this, and this is not at all reflective of our institution, but, you know, this was only last year. So this is something that really, you know, calls in for the need for more education on the provider side as well. Yes, there's a certain level of responsibility that we expect patients to have as well, but we have to take a large part of that responsibility too. I wanted to conclude with just a quote that I found through here that I thought was very pertinent for today's discussion, which is that organizations devoted to a rare disorder continue to be needed and typically arise through the efforts of one or a small group of committed individuals. And I think that's what we're doing here today. We're not only networking, but we're hopefully educating, empowering, and you know, providing you all with a way to connect with everyone. And I think that's crucial and can't stop. Thank you.
Thank you, Abby. That was fantastic. So to finish up kind of the formal talks of the day, we have Dr. Julie Philippi, who's the Pellegrini Chair and Vice Chair of Cardiac cardiothoracic research in the Department of CT Surgery. This topic is highly relevant, not just to the current population, but the children and the children's children and the generations to come. So thank you, Julie.
Thank you so much for the introduction. I'm really grateful to be here and speak with all of you today and share a little bit about what we're doing in the research lab. And thank you also to the Marfan Foundation for being advocates and supporters of research in this area. So we are interested in mechanisms that induce and regulate progression of ascending aortic aneurysms, which we know the many connective tissue disorders are predisposed for developing aneurysm in the aortic root and the ascending aorta. And many of the genes have been identified for these syndromes and mostly well characterized. And we've been interested in many of these and also in another patient cohort that have the congenital heart defect of bicuspid aortic valve. And we had some excellent introduction on the underlying pathology, and I want to just center in on a few more details. What you're seeing here is a cross-section of human aorta, a patient with aneurysm, and the hallmark that you see at the tissue level, this slide here has been stained for elastin, this black stain here, and what's characteristic are these fragmented fibers, which causes the weakening of the aortic wall. And in this region, you also have loss of the smooth muscle cells within that medial layer. So our approach has been to partner with clinicians, cardiac surgeons, to leverage their expertise and develop a robust tissue bank of patient specimens that are procured during aortic replacement operations due to aneurysm, and to partner with transplant surgeons to compare our analyses with specimens that are non-aneurysmal. And some of our areas of interest have been in the cells that make up the aortic wall, the extracellular matrix, all of the proteins that are outside the cell that provide support and signaling molecules to the cells, and then develop model systems in the lab that are based on patient-derived cells and tissues. So to say just a little bit more about the cellular and molecular level of using Marfan syndrome as an example, what you see is defects in fibrillin-1 gene cause the elastin to be assembled improperly. So these fibrillins are microfibrils, and you can think of them sort of as a blueprint for elastin to be deposited and assembled into mature fibers. So in cases with Marfan syndrome, you have improper scaffolding and blueprints, and this regulates a signaling molecule known as TGF-beta. So this extracellular matrix sequesters TGF-beta, and when the microfibrils are faulty, this releases TGF-beta and causes more signaling to the cell. So this is the outer layer of the cell, and then you see activation, excessive activation of this signaling that manifests into various conditions in different tissue and organ systems. So we're interested in understanding how this plays out and looking again at human aorta. What results is a disorganized elastin fiber matrix. And we've learned a lot using mouse models that have mutations similar to human Marfan syndrome, and we see similar effects in the elastic fiber matrix. So some recent work, this study is from a group at Yale, showed that there are, in patients with Marfan syndrome, there's a faulty turnover of elastin, and the patients with Marfan syndrome at a younger age have an older elastic matrix. So this really contributes to the degeneration of the wall. In our group, we've looked at this from a number of perspectives, including the strength of the aortic wall, measuring the biomechanics, looking at the cellular layer and understanding how cells handle free radicals and combat those free radicals, and also how proteins are arranged and their tissue microarchitecture. And I'm going to focus on a few examples on the elastic fiber matrix, and also talk quite a bit about the nourishment of the aortic wall and why it's important. So we've used a fluorescence microscopy approach known as multiphoton microscopy to examine the arrangement of collagen and elastin fibers. And in a normal aorta, we see this nice alignment of the collagen and elastin. But in a patient with aneurysm, you can immediately appreciate that there's a lot more disorganization and misarrangement of these fibers. And in this extreme example, extremely large aneurysm, the elastin here shown in the red fluorescence is essentially not at all in the fibrous arrangement, and the collagen is highly fragmented and highly engaged and being pulled. So this is a way that we can evaluate the tissue microarchitecture. And where it becomes informative is when you can include this in computational modeling. So here it's a simulation of increased pressure in the aorta, and we've mimicked the elastin and collagen fiber matrix here, and see here through this heat map that areas that have lower density of these fibers have higher stress. And this is important at both the tissue level as well as the whole vessel level for making predictions of areas of wall weakening, so we can help guide the clinical decision-making and informed decision-making for when to intervene and replace the aorta as a preventative measure to avoid dissection. So also in the lab, utilizing the patient-derived cells and hydrogels that are based on extracellular matrix, we're creating these miniaturized blood vessels. So this mimics the aortic wall, and we're able to assess the cell distribution, patient-derived cells here, the nuclei are labeled here in blue, and study mechanisms of new production of extracellular matrix. You can see the collagen here in red and elastin in green, newly deposited by patient-derived cells in these tissue-engineered models in the lab. So I mentioned the nourishment of the aortic wall being very important, and several large vessels, arteries, and veins require their own microvasculature to deliver oxygen and nutrients to the inner layers of the aortic wall. And looking here at the normal aorta, we see a nice distribution of these vessels here in the outer layer called the adventitia. Here is where a lot of the elastin degeneration happens, the medial layer, but this outer layer is very important as well. And in patients with aneurysm, we see far fewer of these vessels. It's a much less dense microvascular network. And this has been a microvascular network that's been studied for centuries. Thomas Willis identified this in the late 1600s. We saw the first drawings by a Dutch botanist, Friedrich Reusch, who described all kinds of vessels around the aorta and the heart. And it was Ludwig who coined the term vasa vasorum, Latin for vessels of vessels. And if you search the literature, you'll see a lot of mistakes and misnomers for this really intriguing microvascular network. But as we look forward to centuries more of new knowledge, you can think about it as arteries within arteries. Looking a little bit closer at these vessels, they are conduits for inflammatory cells, and associated with this dysfunction, we see hypoxia within the medial layer. So this red label here tells us where there's low oxygen delivery to the aortic wall. And it's, I think, not a coincidence that it's found near areas of intense elastin degeneration. You can see less green signal here for elastin compared to a normal aortic wall. And we find that these microvasculature, this network is leaky. We can see red blood cells leaking into the tissue here, showing a vulnerability in these microvessels that nourish this larger vessel of the aorta. So this is a very heterogeneous microenvironment, lots of different types of cells. There are progenitor cells, there are fibroblasts that secrete that extracellular matrix, but we've honed in on the cells that make up these microvessels, endothelial cells that line them, and pericytes that wrap around these small blood vessels. So here in the section of human aorta, the red label here are pericytes wrapped around green endothelial cells. We have culture expanded these in the lab, and when we place them on gel-based substrates, they have this really curious behavior to spontaneously ball up into these clusters, and then they start to project some sprouts that's reminiscent of early vasculogenesis or new blood vessel development. And a normal patient here, patient-derived cells have robust sprouting. Cells derived from an aneurysmal patient have less sprouting emerging from this, what we call spheroid culture. And we're testing some ways in the lab to promote additional sprouting here by supplementing their cultures with normal ECM from that outer layer. And we're also working with polymeric scaffolds that can be precisely designed to mimic those extracellular matrices that we see in normal versus aneurysmal tissues. So here, the star of the show here is this spheroid kind of dancing around and pulling on these polymeric fibers. But we're also taking note of these cells out here in the periphery that are choosing not to assemble into spheroids, preferring to stay on these bordering fibers that are of thicker diameter. So this is one platform that we can study the physical cues of the matrix, things like diameter, alignment, and spacing, and how they influence these important cells. And one other area that we're developing that we intend to lead to new therapies are these biomaterials that can encourage new microvascular growth. So we want to restore oxygen to the medial layer. And so this is a in vivo model. It's a chick embryo membrane model where we've placed a hydrogel directly on the membrane, and the pink is an overlay of new blood vessels with nuclei. So we see some encouragement of new vascularization towards our biomaterial compared to a negative control where there's no new blood vessel growth. And in this proof of concept assay here, these biomaterials can be aerosolized or sprayed. We're using a polymeric scaffold here to show a nice deposition of collagen, or extruded. So we're envisioning this could be a biomaterial that could be delivered in a less invasive surgical manner and serve as a preventative treatment. So what I hope you'll take home today, in addition to confidence in the clinicians that you heard from, is some information about what's coming down the road and what we're working on the research side. And we've spent a lot of time trying to understand the different types of aneurysm and the molecular mechanisms that govern those aneurysms. And we've centered in on the microvasculature because we see that their remodeling is uniformly associated with ascending aortic disease. And some of the experiments we're developing now is to discern whether this remodeling is a cause or consequence, and potentially could be a vicious cycle that we can therapeutically target. We've centered it on important cells of pericytes that we could potentially harness for therapeutic benefit. And we're working on some biomaterials that deliver important cues to harness those endogenous cells, in theory, to regenerate the vessels and deliver more oxygen and nutrients to the aortic wall. So this is a large team that contributed to some of the work that I presented. We want to take every opportunity to thank patients and their families who consent to donate their tissue to our research efforts, and we have excellent support from institutional leadership. So thank you very much for listening, and look forward to your questions.
Slight modification. Julie, if you don't mind just staying back, let's do our panel. So if the speakers in this session could just come up, we can do a few questions before we close out. While folks are coming up, so once we're done, I think Angie can give it a little bit more details, but our social event is at Shorty's Pints and Pins. There's duckbill bowling, foosball, arcade games, etc. My in-laws are visiting, and I really tried to be able to join you guys, but I think I'm gonna have to go home after this. But most of the folks are gonna be able to join, and Derek's kids, as he said, are already experts at this. So if anyone has a question, we can get started with the panel.
So yes, thank you for this question. We actually see a downregulation of proangiogenic signals in that microenvironment, which is counterintuitive. You would think that the hypoxia would trigger an angiogenic response, but we're seeing, quite honestly, the opposite. But chronic hypoxia can actually be a reason for that. So what we're doing with the biomaterial is delivering more angiogenic signals to compensate.
So the first one you might not know the answer is, what is the age demographic of people who have these disorders? It seems like a lot of what we hear is towards the younger patients. I'm middle-aged, and there are some other people here who are as well. So I'm just curious what the demographics are on that, and is there management that's tailored more towards people who are now maybe beyond just the vascular issues, but the other long-term aging issues that come up with these disorders, particularly with like bone health and immunology and physical therapy.
Yeah, I think Dr. Hoskopal.
Yeah, sorry, I can take the question. That's a great question about the demographics. We are making earlier and earlier diagnosis now because of the era of precision medicine and gene diagnosis and family testing. So though it seems like the patients are getting younger, it's just that we are diagnosing earlier. And the other end of the spectrum, people are living longer as well. So both ends, there has been an increase in the numbers. So yes, as one lives to be older, there's more focus, not just on the mortality, but also the other stuff like physical health, ocular health, and mental health, so on and so forth. So for a simplistic answer would be both ends of the demographics are increasing.
I think for the older patients, I mean, you cannot leave the ER if you go. I mean, you could go there with a cough. You're going to walk out with a CAT scan. So somebody, is always getting imaged for a variety of reasons, and a lot of times in a good way. Even though we do this over testing, patients get, conditions and patients get picked up. So, and we see this a lot in the adult population.
Do females with connective tissue diseases have a harder time getting pregnant?
Yeah, interesting question. I think when we look at perhaps data from patients that pursue in vitro fertilization, so after, typically that's usually after 1 year of sort of trying naturally to get pregnant. I don't think there's been significant differences between patients that have connective tissue disease versus not. There's a lot of different factors that go into infertility. Connective tissue disease specifically has not been shown to have increased infertility that I know. Dr. Wolf, if you know that.
That's really where
Right.
my brain went.
Yeah.
And, I missed my chance.
Yeah.
But I just wanted, I could do something great.
Yeah, I think there's a lot of interest in what role do sex hormones acutely, thinking about pregnancy and menopause, and then really chronically, differences in male and female sex hormones. How do those differentially impact, say, the arterial tissue? And so I think there's going to be a lot of data coming down the line that maybe males and females, disease progresses differently and they have risk for different things.
I was wondering if there's any connection with connective tissue and hearing loss. I have hearing aids, and I never heard of a connection with Marfan's and hearing loss. I don't know if anybody knows that.
I say, is there an ENT in the room? It's like that. I don't.
We need an ENT.
I don't know if I've seen that data before. I think it's a very good, interesting question. Yes. Oh, wonderful. Okay. Did that mention that there was a higher risk than in general, maybe with just aging and? Okay. Yeah. Yeah. Thanks for bringing that forward. Matt had mentioned. Yeah. Yeah. And I think that you had asked about osteoporosis risks and things like that. I think there's no data that connective tissue disease would predispose you, I think, more or in contrast, be less, you would be less likely. So I think in addition to all of the sequelae of connective tissue disease as we age, we of course worry about things that impact all populations in aging, like osteoporosis, particularly in postmenopausal women. I don't know if I've seen that data, but it sounds like that is something I'm learning. Ben, that's great. I wonder if you're saying for children? Gotcha. Okay.
I think from the hearing loss perspective too, a lot of pediatric patients can have those palate issues. And, as we can see things like a soft tissue palate, cleft, or a full cleft palate issue and things like Louis Dietz. And that can sometimes impact all of these ear tubes and things like that, where kids are more prone to things like ear infections and fluid in their ears, and that can pose a risk for hearing loss and things like that. So that's probably what they're looking at Johns Hopkins, is probably how that all interacts together. So usually with genetic testing, we do recommend someone in the family that we know has the most kind of stigmata of the condition that we're dealing with. So someone that's had a dissection, has a lot of the physical features, so that we can truly identify what that particular marker is in the family, and then use that then to test other at-risk family members. So as Dr. Torek mentioned earlier, some of these conditions, we don't always see all of those markers on a physical exam. And in young children, we might not always see those markers, when we're evaluating you right away. And so knowing, what the specific genetic cause in the family is can really help us kind of say to your relatives, yes, you have that trait, or no, you don't, with the genetic testing. So. Sure. And there's a lot of really great avenues to access genetic testing. Genetic testing used to be really, really expensive, thousands and thousands of dollars. And the self-pay costs for a lot of these tests now are under, $250 or less. So, and we find that insurance does cover this a lot of times, when we use the right language and, we're advocating really strongly for the benefits of knowing about these diagnoses and the preventative aspects of care that we can have. Insurance will really pick up on that, and usually will offer to cover some of those costs. So. Yeah.
Test me and say, like, you have that, all of my medical history.
Well, we could look at testing for you, and then, we have resources to pivot and test family members. But yeah, I think a lot of times people think of genetics as a very scary place and very complicated place. But, we have people that help navigate that process, and that's what I do as a genetic counselor. So I'm a pretty big advocate for, getting just plugged in with a good center like what we have here that can help you navigate that process. So, yeah. Didn't get there yet.
Chris, let me, as long as you have the mic, Chris, if you don't mind. So we talk to patients sometimes, and they or their families are very hesitant about getting genetic. So what are the top 3 reasons patients hesitate to get it done? And tell us why they may not be accurate.
I had a family, I think from the pediatric perspective, sometimes it's really nuanced things like, I don't want to stick my kid. I don't want to bring my kid in for a blood draw. So I had a family that was their main reason. And when I explained, we can use a cheek swab kit instead, they were like, oh yeah, okay, I'm on board. No big deal there. I think a lot of times too, it's just that you're going through a lot. You might have gotten this diagnosis in the context of, a major event or surgery, right? And the focus has been on that. And you want to kind of get through that process before you approach why this happened, and getting more information, more news to digest and process, right? And the other big thing that I often will hear is insurance. So families worry about insurance discrimination for life insurance and all sorts of other things. Usually what I explain to families, those are the very reasons that's bringing you in to have these conversations around testing are reasons that like life insurance industry, and underwriting and things like that are going to look at in the underwriting process. So, they take that into account whether you have had genetic testing or not. And, they're savvy. They know how to ask other questions to kind of get at what your risk factors might be. In kind of a big, broad scope. I think the Marfan Syndrome Foundation, you guys did a webinar maybe a year or two ago about life insurance, and it was so helpful. It's a really great webinar. I think it's on the YouTube channel, right? And they talked about some of these issues about life insurance and applying and variables, and it's a very gray space, and it's not black and white. It's not, oh, I have this diagnosis and I'm never going to be able to get life insurance or life insurance for my kids or my relatives, or disability insurance and things like that. It's really, there's very much nuances to those discussions. So, and really, truly, again, a plug for genetic counselors. Like, that's what we do. We help navigate those conversations with families. So.
Can I quickly add to that? And thanks. Those are the most common reasons we hear why one shouldn't get tested. And if I go on to the other side and why we should get tested is, this is the era of precision medicine. We have an accurate diagnosis once we get tested, number one. Number two, there are variances in all of these connective tissue disorders and how we treat. Not just medically, also surgical thresholds are different. And then last but not the least is the extra cardiac manifestations are also different. There could be some genes which are associated with coronary artery disease, for example, heart attacks. So we know what to screen for in those patients. And last but not the least, it's the family. We can go at, if we have a panel for a patient and then there's one gene positive, for the at-risk family members, we go after just that gene. And it's like a cascade testing. And so then we can identify early, start preventive treatment early, and hopefully at the end of the day, avoid catastrophe.
Is there any place for considering estrogen replacement therapy for postmenopausal women with connective tissue disorders?
Do you mean for vasomotor symptoms of menopause or?
Is there any benefit to the connective tissue elasticity or strength of connective tissue?
I have never seen anybody get hormone replacement therapy, and I'll ask the group too.
Asking if there's like an additional
Particularly
benefit.
for vascular strengthening. There's been a lot of studies just for, in regards to cardiovascular risk, and there's a big women's health initiative study that looked at should we give postmenopausal women hormone replacement therapy to prevent cardiovascular disease, and that was not only not positive, but actually showed some evidence of harm. So we've actually kind of gone kind of away from that. But as far as that, particularly for connective tissue disorders and prevention of, say, aortic growth or dissection, I don't know any data on that. I don't know if anyone else can speak to that. Your data.
Extremely controversial, I feel like, amongst most cardiologists and OB doctors, and some people swear by it, and others, because of that Women's Health Initiative, say that it has been shown to cause an increased risk of heart attack and stroke in women. It does seem like timing plays a role, so the sooner you start it and the sooner you finish it, the lower that likelihood of getting stroke or heart attack is. But we are often cautious to use it in people who we think are at high risk of heart disease because of that signal in that big Women's Health Initiative study, which was, I think, hundreds of thousands of women surveyed about their heart history. It was probably done like 2 decades ago now. But I think this is something that people are going to continue to look into because the data is a little bit murky and we don't really know what the answer is.
And my wife has beds. We live in Moundsville, West Virginia. In the summertime, we're up in Cleveland. So she has a lot of doctors that follow her beds in Cleveland. Wintertime, we're down here. An emergency situation where something ruptures, they're going to life flight her. Probably to UPMC, being closer than Cleveland. She has some doctors here, but not the ones that really treat her beds or watch her beds. So how do you guys coordinate with UPMC in Cleveland? Do you guys, communicate, or how should we go about that? Should we have a doctor here too that follows her, or what do you think?
So that's a great question, and I don't have a great answer to it. So what I can tell you is the following. When it's an emergency, the goal is to be able to take care of that particular emergency. Obviously, if we have an established relationship, it's different because, we know you, we know what the anatomy looks like, we know what we need to do. I would say the most important thing is you should feel comfortable wherever you want to go, right? I mean, this is about you. This is not about us. This is not about UPMC. This is about you and right. So when it comes to an emergency, you want to be able to go to the closest center that does high volume surgery for acute aortic dissection. And both Cleveland and us do about the same for acute aortic dissection. Cleveland likely does more for elective aneurysmal disease. But when it comes to acute, we have, at UPMC, we've consolidated a lot of the dissection centers. So for example, just a handful of us that really most of them are here between Dr. Singh, Dr. Serna, and myself, really take care of all patients with acute aortic dissections as opposed to 25 or 30 surgeons in the system. And the reason we do it is not because individually we're better, because there's as Dr. Serna described, there's a volume outcome relationship. The more you do, the better you get at it. And the infrastructure support, it's everyone that's sitting up here, everyone that you've heard from, right? It's our APP team that sees you in the office, that take care of you in the hospital. It's our ICU docs, it's the anesthesiologist. It's really the whole team that is immersed in that high volume and intense acute situation, which allows patients to recover better.
Yes, I have some of my doctors in Cleveland, but I developed a relationship here. I picked here and found a PCP for the reason that we live just an hour outside of here. And when my pseudoaneurysm dissected 3 years ago, it was here that took care of me. So, and it was just after that the discovery of the VEDS happened, and then through this genetic counseling at Cleveland, they partnered here with UPMC. UPMC said, well, if she agrees to do the whole gene sequencing here and the pharmacological gene sequencing, that they would take care of that, and they've been really excellent. That is how I established with the PCP, but I don't have certain specialists that need to be gotten on the team, and I've been waiting to do that, following this and my next meeting with my PCP, because my nephrologist and my vascular surgeon are having a very difficult time with my blood pressure. VEDS isn't typically such high blood pressures. And so if I can't get that managed, my VEDS is the complication because of my high blood pressure. So how do I start building the team here is what we're here more months out of a year than we are.
Yeah. Absolutely, and as I mentioned, I think, thankfully most of the folks are here. Once we wrap up, maybe we can connect with you offline, get your information, give you a call, and see how we can get you plugged.
Can I say something real quickly? You can talk to doctors all day long, all night long about the benefits of, and the lack of benefits of electronic health records. We all hate them, but they actually have some amazing things about them. And one of them is there's a company called Epic, which is kind of interesting. It's owned by one woman, came out of her master or MBA thesis, I believe, and it comprises maybe 40% of the health records in America and all of the academic medical institutions in America, from Harvard to Johns Hopkins to Penn, and includes UPMC and Cleveland Clinic. And when you're seeing at a hospital that uses Epic, and you sign a waiver, I believe it's called Care Everywhere, we can see all of your records. So if you go to a UPMC doctor and a Cleveland Clinic doctor, we can see each other's notes, which I think is extremely valuable.
That's a great point. Great, we'll carry this discussion more as we try to beat each other at bowling. All right, thanks. Appreciate it. Real quick, Helene has a few points to make, and we'll try to get you guys out of here. Yeah.
All right. Actually, I'm going to do this because you can see me. First of all, let's give a big round of applause to all the docs tonight, please. Thank you, guys. You know, I go to many of these, and I have to say today was really great. I thought your presentations were excellent. The Q&A was great, so thank you. I learn something new every time I go to one of these. Just a couple of things I wanted to mention because that the docs were talking about. So the new AHA-ACC guidelines that they were talking about and referencing, we have a great video on our YouTube channel. I highly recommend go to the Marfan Foundation YouTube channel. We have over 100 great presentations, and they're geared mostly to patients. I would say 95% to patients. That section is in our aortic health playlist, but you can just peruse and go where you want to go. Second is this session is going to be put onto our YouTube channel, hence why we are videotaping. So you can go back and reference certain pieces that were talked about today. Also our physical activity guidelines, a lot of our professional advisory board were important writers on the papers, so please look onto our website because we have a lot of great information on physical activity guidelines. I want to talk about the quality of life, aging, and mental health. We have an amazing new mental health task force, and we just put a bunch of brand new quality of life and mental health resources on our website. So I highly recommend you go to the marfan.org website, and it's all connected to the Lois Dietz site, and also to, it should be connected. I'm going to say should be connected to the Lois Dietz and the VEDS movement.org sites. If not, it's going to be on the marfan.org site. So we have a great task force. We got a nice donation from a donor to focus specifically on mental health, quality of life, and aging challenges. So to your point, this is something we're really focusing on as the population ages, which is wonderful, and the challenges, or not challenges, life challenges that come along. We also have, we're doing a lot in Spanish, so if you have any friends in the Spanish-speaking world, we'll be having a summit only in Spanish, end of January, global. It's going to be an all-day session. I think it's Saturday. I think it's the third week in January. We're also going to be having a bunch of new webinars in January, so look out for emails from me and from my other colleagues. Sometimes we go into spam. Please check your spam or check your other emails. I'm trying to think of what else. And if you ever have a question, you can go right onto our website at marfan.org, ask a question. It goes to our nurse. And Jan, our nurse, is amazing. She may not respond within the first half hour. She usually responds within 24 hours, and she is amazing. The docs here all know her because she contacts all the docs when she has questions, but Jan is an amazing resource as well. I also want to talk about Center of Excellence, as we talked about that. We have a resource guide of an institutional directory, and all of the institutions that are on there have to go through a pretty rigorous survey. Of course, University of Pittsburgh is on there with everybody's names who pretty much spoke today. So just know you are in great hands while you are here at UPMC. We take pride in all the folks who are on our institutional directory, and they are from all over the country there. And I think that is it for me. Don't forget, a couple things. Walk May 18th. We will be back here at the park. It should be on your tables. So we'll be back here with a bunch of colleagues. And February is Marfan Awareness Month. We just finished VEDS Awareness Month, so a bunch of new resources for the VEDS folks. Go onto the vedsmovement.org site. If you haven't been on there, a lot of great new resources. February, Marfan Awareness Month, and June is Lois Dietz Awareness Month. So we have a lot of stuff going on over the next, I want to say 6 to 7 months. So just keep looking at your emails. Just a word of advice, if you decide to unscribe, we're not that sophisticated, you'll get nothing. So it's either all or nothing right now. We're sort of figuring that piece out. So we are going to be doing a lot of surveys over the next 6 months. We're getting a little more sophisticated, but don't opt out because you won't get anything. So just a word of advice there. And I'll be bowling. I'm not very good, but I will see you later. Any questions, feel free to find me.
Thanks, Elaine. We'll wrap up. Thank you again to Dr. Hoskabal, Dr. Singh, Alyssa, Angie, Krista, for really helping us put this together. Thank you for the Marfan Foundation for giving us this opportunity. Thank you to all the speakers and the providers and the docs who were able to come here, really share their experience with us. And most importantly, thank you to you all the patients and family members who really took some time off of their Saturday to spend with us and allowing us to really be a small part of your journey living with us. So thank you so much and have a good rest of your week.